welcome everyone to the annual conference of sickle cell disease in India. Every year we have been doing, and this time we have kept it as theme as changing sickle cell scenario in India. So when we say changing scenario, it has many connotations. First connotation, that people sitting here and joining online have a belief that there is something changing, a lot we can change, and we are seeing that in sickle cell, a lot of things have come into priority in last couple of years, and our Prime Minister has also announced that we want sickle cell free India now. So this is the online have a belief that of there is something changing sickle cell scenario in India. Now we have audience here. Every year so far it has been, this meeting has been online. We have been having about 500 to 600 delegates. This year, so I will welcome the online audience, where we have 550 registrations from India, about from 190 cities. Out of India, about 22 countries, to name a few: UAE, Ethiopia, Vietnam, South Africa, Nepal, USA, Sri Lanka, Bangladesh, Philippines, Qatar, England, France, Pakistan, Malaysia, Germany, Oman, Myanmar, Portugal, Brazil, Indonesia, and Spain. So this is the way things are catching up. So a lot of interest in sickle cell, in what our different states or central leadership is doing in sickle cell. So with that, I would like to invite Program Director Dr. Dinesh Pendharkar. As you know, sir, do not need any introduction as such, not just in India, but globally. He has been working at the block level, village level, doing 3 camps, 4 camps every day in cancer and in sickle cell. So, sir is Director, Ceremonial Cancer Center here, and he has been past President of ISMPO, ISO, and Chairman ESCO International Affairs Committee, and he wears so many hats. And he is one of the believers that in sickle cell we can make a big change in India. Over to you, sir.
Thank you, Rajesh. So as this program is physical plus more virtual, because there are so many people interested in this topic, we have decided to make it really global. And sickle cell, as you know very well, has really taken up, is a lot of social interest, lots of political interest, and there are, I would like to say, around 300,000 patients in India who really need help. They are being treated, but the aim of the whole exercise is to find out the ways how we can offer them better care. The care is being offered. The diagnosis is happening. There is a mass level screening going on. It's really a huge screening program turned out in the country, and it's really going on well. So we are on a positive note. We are doing well, but we have to define how can we do better. I am extremely grateful to my speakers who have taken time and come here from very long places. Amongst us, we got Professor Jaina, a renowned hematologist and in charge of hematology, President, Indian Society of Hematology, Blood Transfusion, who has been a pioneer in this area from Odisha, and we know Odisha is one of the biggest, highest prevalence of sickle cell disease. Then we've got Dr. Dinabandhu Sahu, who is in charge of this specific program in Odisha. We got physically sitting with us people from society, from NASCO, Dr. Gautam Dongre, Lalit from Rajasthan, a doctor from Valsad. So we really have very important people. We got so important people that they can actually make a difference. So the situation in India is we have more than 300,000 patients. That is what we believe. I am sure within 6 months we'll be able to generate the exact numbers. But on an average, every district has listed patients of 1,500 to 2,000. The districts which are with prevalence. I have done at least 10 to 15 districts in last 1.5 years. I've physically seen more than 5,000 patients in last 1 year, so I really know their plight. I have done blocks in some districts. So our mission of Sarvodaya Hospital has been to really try to come up with a program of assistance to sickle patients. So we are doing a big program which I will announce you and let you know later on. So ours is a big center. We specialize in a lot of things, including transplant. This is our cancer center where we are sitting. So in last 1 year, what was actually interest of my department with my friends from the districts, we had got publications on various topics. So we reviewed the topic of transplant because we thought, unfortunately, in India, transplant is not being promoted for various reasons. But now we have a capacity of doing transplants in every deserving and wanting patient. So if patient deserve transplant and patient is willing for a transplant, he can come forward. Lot of agencies are there to help. So transplant is physically feasible. So I want my friends to spread this message amongst patients. It is available. What is criteria? Who should undergo? We can discuss this in later. So we not only tried to explore India, we did a special visit to Africa and studied sickle cell disease in Africa just to compare, because we always used to say Indian patients are different. So we really wanted to see. We did a big study in Burundi, in Central Africa, and also tried to understand what is the difference between two patients. At the same time, we know that levels of HbF levels in India are different than in Europe and then in Africa and America. So mean HbF level in India is 21, 22. Mean HbF level in Middle East and Africa is 9, 10. So we are already, as far as HbF is concerned, we are definitely different than Africa and America. This is very important from treatment point of view. So we have to, this is our biological difference. We have really seen what kind of patients are coming, what is their age, what is happening. So mean age, with the data available, the mean age is about 17, 18 years. And in our list, so we are already analyzing something, the age analysis of the whole group, and we'll come up with some interesting data which I don't want to disclose now. So we had 2 publications in American Society of Hematology annual meeting, where we actually tried to study which patients are eligible in India for transplant. And what we can say that among 251 surveyed children, we could find out that 72% had VOC, vein-occlusive crisis, in 1 year. This is as per the eligibility guidelines of the American Society of Hematology. We can design our own guidelines, but as per them, these many patients actually qualify for episodes of fever, 51% qualification for transplants. So we can really go and really understand. The American Society of Hematology guidelines say if there are multiple admissions required in a year, the candidate is for transplant. So we have to increase focus on transplant and should not wait for medical problems for the patient to occur after some time. We are not talking about hip replacements. We are not talking of kidney replacements. They are also a very big problem. And we did one very important survey of healthcare workers. So we have a very large survey. This was not a very big survey. This was only about 416 healthcare workers. But now we have done additional survey of another 600 healthcare workers. And believe it, they have, if I may say correctly, no knowledge of sickle cell disease. No knowledge. I mean it. Why this is important for you is ultimately we are dependent on them to treat sickle cell disease. So our first target has to be, if we really want to improve the situation, we have to educate healthcare workers, and especially in the periphery. These are tribal districts, villagers who cannot come to a major town. Even coming to a district headquarters for them is a challenge. Because that is a challenge, we have to train healthcare workers in the periphery. So unless we, as a first part of the program, our first part should be training of peripheral healthcare workers if we really want to improve the situation of sickle cell disease. Is it doable? Absolutely doable. I have physically trained all healthcare workers in 3 districts. We have done it. So we know it can be done. We know how it is to be done. There's a lot of material available, but somebody will have to take it as a task, and probably state will have to get involved to create this sickle education program for the healthcare workers. Patients we are doing, that's fine, but we'll have to educate healthcare workers. And so this is one of our abstracts which got published in ASH. We did multiple camps. I have done really huge number of camps in last 1 year, because I really visit these districts physically, and we really know the plight of sickle patients, and we really want help of everybody, because it's not no one man's game. All of us will have to do something. This is our camps in Odisha. So you can find the children coming with these fingers. It's all existing. So these symptoms are there. There is no big deal diagnosing and thinking about it. Fortunately, government has done a great job by offering free diagnostics. Madhya Pradesh, Odisha, Rajasthan, there is a free diagnostic facility in the district hospital. You give the sample, your blood report will be done. So there is nothing stopping us from diagnosing this patient. Hydroxyurea is available in every district hospital free of cost. So there is nothing stopping us from treating these children or patients. So this was our camp in Odisha. There is one sub center, one of the blocks. So in one district, I have done all the blocks physically. So I know what is actually, we did because we really wanted to understand with my team what is actually happening. We have done trainings of medical officers. So our team has done training of medical officers. We've done multiple activities in India. We've done multiple activities in Africa. Idea is trying to gather information so that we can perform better. We have a big team. I got with me a lot of people working with me here who come forward, who go to villages with me. And so it's a big team really doing this work. And besides me, we have got really team working in the periphery. So in every district of Odisha, we got one medical officer whom we have trained in sickle cell disease. He is a big support to us. In Madhya Pradesh, we have trained doctors in sickle cell disease. So they are helping. So we are trying to keep, but this is very small number. Ultimately, I will have to go to periphery to every doctor. That will be my really big aim. If you really see the problems, the bone problems in these patients, it's phenomenal. It's huge. We need to address them. So these are our African activities, and we are involved in pediatric hematology and oncology for last many, many years. So there is a reason why we are in this space. It's not today's space. We actually started working with thalassemia and sickle cell anemia like 40 years back. So this is what I would like to tell you the situation of sickle cell disease is. So the salient features is the number is huge. All of them require care. Care can only be given if we empower the peripheral physicians. No one institution, no one doctor, no one hospital can take care of these patients, because these patients are physically located in remote areas. They cannot travel even to the district level. So we have to evolve a model of care of sickle cell patients everywhere. As far as diagnostics is concerned, fortunately, it's being done in an extensive, large scale. More and more patients are being picked up. More the reason for us to be really more powerful to do all this. Because now I have found out the patients, I need to offer them service. Can we offer service? Yes, we can. But I will have to educate my primary healthcare worker. Is it doable? Yes, it's doable. So nothing is impossible. Fortunately, there is no problem with people. People are willing to learn. No problem with the funds. Government is already spending a lot of money. A lot of NGOs who are coming forward to help, they are available. So for example, I have a funding available for assisted bone marrow transplant. And this assistant level is huge. It's you can't even dream how much we can assist to the patient. But now we have to identify a proper patient to offer him a proper treatment. So I'm sure this year's Sickle Cell Day will give us a lot of opportunity to raise concerns about sickle cell disease, to involve more people in the program, and to really help the needy sickle cell patient. Thank you. Our next presentation today is by Dr. Tulika Seth, Professor of Hematology from AIMS Delhi. So as you know, she has been the coordinating member of all government committees working on sickle cell disease on all hemoglobinopathies. So she will be speaking on what are the challenges and what probable solutions could be there in the country. Dr. Tulika? Hi. So, voice.
You have really here decentralization care, not only for sickle but also for oncology. I hope I'm audible.
Yeah, now you're audible.
Okay, so I just wanted to say I want to commend you for your pioneering work in decentralization of care, which is really what is required in our country. And you've pioneered this in the oncology field, and now you're pioneering it in the sickle cell field. And your dedication and your publications are wonderful. You're changing the landscape. And I also want to say my pranam and namaste to the esteemed team you have gathered, Dr. Gina, Dr. Italia, and all the experts at the venue, because all of them have really been leading the march in sickle cell. So nothing can be done in isolation. It is everybody's work and together that is going to get us somewhere. So I hope my slides are visible.
Yeah, sorry.
I hope my slides are visible.
Yes, slides are visible. Everything is fine. Go ahead.
Perfect. So the situation in of sickle cell has beautifully been discussed by Dr. Pendharkar, and in a country the size of India, and with all the states having different diets and different cultures, there is no reason why the sickle cell also should not be different. And by my discussions with doctors from all over the country, I now feel that the complications that are often seen in sickle are not necessarily all the same in all the patients. And so I think it's really wonderful that we all work together to get more data on the differences of the manifestation of sickle cell disease in patients from different regions. The problem of sickle cell is that the majority of patients live in countries like different countries of Africa, as well as India and other countries where the health economics is a little bit different. Though patients in the Americas also have sickle cell disease, but there their access to treatment is much more. There are many countries where newborn screening has been done for many, many years, so they're able to identify all the sickle cell disease patients right at the newborn period. In India, we are fortunate that certain states like Odisha have pioneered the newborn screening, but it is not uniformly available for the rest of the country. And not identifying these patients in the newborn period is a major challenge. And unless we are able to do that, we will not be able to allow these children to have early access to treatment. The impact of sickle cell disease on the mortality has been documented by some very good publications from different parts of the country. And we know that they have severe complications, and they can have, organ damage, crisis, and other things. But we have to realize that this was all from the era when early diagnosis and regular access to good treatment was not being provided. So saying that somebody has poor quality of life and complications when you're not treating them is not the complete story. We know that patients have vaso-occlusive crisis. That is the hallmark of sickle cell disease, and many patients can have repeated crises. But often what we see of patients that are referred to us from different parts of the country is that many patients are on very low doses of hydroxyurea, or they're not taking it regularly because they have some beliefs that this may cause problems. So with good care, many patients will do very well. So I think that's one of the things that we must remember, is that we should not underuse the available care that we have, because the lower doses and underutilization and lack of adherence is definitely a problem. Yes, there are also patients who have intolerance to hydroxyurea or failure to hydroxyurea, but and those patients also need to be identified, because there are now newer therapies, and these are the patients who should definitely go for bone marrow transplant or for the newer treatments that are coming up. We until now did not even have a liquid preparation. So for a very young child, taking, the capsules or even the tablets was very difficult. But we're now fortunate that we not only have a liquid preparation, but we also have dispersible tablets. So that is definitely going to make treatment for younger children definitely important, because the earlier we start treatment, the less chance of having organ toxicity and complications. So that is there. And though we have some very good publications that I just showed, but again, knowing the number of patients that we have, we need to have more data on the hydroxyurea patients who are either failure or intolerant. The severity of VOCs is actually considerably more than what would be expected in patients who have such a high fetal hemoglobin, because often people say that the Arab Indian variant is milder, but I really don't feel that it is milder. And maybe when we are able to early diagnose and early treat, we may see some difference in the disease. But at present, we have many patients who have different types of crisis. We frequently do exchange blood transfusions for patients with hepatic sequestration, and as I said, many crises, including stroke, are there, and we even have patients with cardiac involvement. So patients who have VOC in India often get hospitalized, but another unmet need is to document the patients who manage their VOCs at home. So we don't really have complete data. We only have data of what is happening in the hospitals. And if we were to look at the home data, we would actually see that things are actually even more bad. And these are some very important publications from Orissa and other places that document this. And as I said, what we think is that probably a quarter of the crises are managed at home or in the community. So that leaves the documentation for only half, but it actually may be even more. And obviously, this leads to a lot of quality of life issues, with a lot of stress on the patients and their families, because they don't know when the next crisis is going to happen, and they always live in fear of this. There is also a significant financial burden on the family as well as the state and society, because many of these children are not able to deal with their disease. So the National Sickle Cell Anemia Elimination Mission came up. The aim is to eliminate the health burden of sickle cell by 2047. So this is one strategy to which we are all aligned. And I think this is a very important move that the government has made. And it's wonderful that everybody is coming together to participate in this and to help with this. So there's several components of it, which many of you may be familiar with, but some of you may not. So I'll just quickly go over. So we know that the Sickle Cell Mission has been created because of the immense need for this, because at the moment very few patients are able to go for bone marrow transplant. Gene therapy and CRISPR editing are hopefully coming, but at the moment we need to make sure that the patients who are living with the disease have good management, so that we can reduce the complications and improve their quality of life. We also know that many of these patients are living in the last mile, that is in remote areas, so we need to reach them. So several of the strategic pillars for this are the primary prevention strategies, which include a lot of IEC and awareness generation, and this is where it's really important. And as Dr. Pendarkar highlighted, even healthcare workers are not aware. And generally, the healthcare workers will have the same beliefs and knowledge as in the community. So that means if the healthcare workers are unaware, then the community is also unaware. So a lot of awareness has to be done. Just the way that I think it was done for polio and for other diseases, we need to have a lot more activities on the TV, on the radio, and have people talking about it. Secondary prevention is really important as well, because this is how we're going to be able to identify all these patients and make sure that they go early for treatment. And then we need the holistic management and continuum of care, because there are many patients right now who are living with the disease. And I think there are many things that we can learn, and we should work towards a multimodality treatment to support these patients and include all the healthcare providers in the community, and so that no one feels that they're left out, because everybody, I think, can contribute to the treatment and the rehabilitation of these patients. So the scope of the program is actually very ambitious. In India, if you want to do something well, you have to do it in a big way. And the plan is to screen the whole population from 0 to 40 in the affected states. And this is going to be a really big amount of work, and this cannot be done without the participation of everyone, because we're looking at screening 7 crore people in the next 3 years. And the good thing to note is that quite a lot of this work has already been underway. So the main focus will be on 17 states which have a higher prevalence. These are the states, and many of the representatives from the states are already present. So you will be well aware of it, and you must already be working on this. And it is going to be adopted first in these areas, and also in the non-tribal areas, not just the tribal areas. They want to converge with many of the already very important government programs like the RBSK and the Pradhan Mantri Surakshit Maitritwa Abhiyan and the Anemia Mukt Bharat. So if we can link with all of this, then this will definitely help to speed up the program. The primary prevention is the most important. When I worked on cancer awareness, I realized that it's really, really important to have good people out there talking to the families, because, just having posters and pamphlets doesn't really do the trick. In order to change a person's belief and to give them good awareness and knowledge, you need to have doctors or other people who are trained in communication to talk to the patient so that their myths and conceptions can be removed. This also needs to be done at school levels, at health facilities, basically at every opportunity that you can, because the level of awareness needs to be increased. Without that, people will not access care. These are some of the sickle cell cards that the government has decided to use, and they have recommended many strategies of IEC with the mass media. And also they've engaged NGOs, which I think has been very important, to talk to families, to do premarital counseling, and to offer prenatal screening services where not available by the government. So I think this is really important, because NGOs can often bridge any gaps that are there so that we can reach out to the maximum number of people. The secondary prevention by universal screening and early diagnosis is important, because the earlier patients are identified, they can be offered treatment, and they can avoid the complications like the bone complications and the pulmonary artery hypertension and other sequelae that we are seeing, because those sequelae are because of inadequate treatment. At the moment, we will have many patients who probably will have end organ damage and may need transplant. In future, I think if we can identify patients very early and give them proper treatment, those numbers can hopefully be reduced. Camps are another way of identifying patients who are not presenting themselves to the healthcare services. The screening has been advised to be done in a phase-wise manner, with the high prevalence blocks at the beginning. So the grade A and B blocks, where the prevalence is up to 30%, is going to be done in the initial strategies, and then subsequent blocks with less prevalence can be done later. So this can be, and in the group D, we can have a targeted screening, maybe a cascade screening for patients already identified, rather than a whole population based screening. The newborn screening is immensely important, and I'm really honored that Dr. Gina has taken this up as an eminent hematologist in his state, because this is, I think, very, very important. We must not lose any baby, and every child who is identified can be then offered penicillin prophylaxis, and later on we put early on hydroxyurea, and now liquid hydroxyurea is available. So identification of persons with the ABA ID and then subsequent a confirmation test is very important, because often what is done is screening is done and then patients lose the reports, and that very valuable information is lost. As Dr. Pandharkar said, the screening, we now have very, very sensitive kits, and there's multitude of them now available in India. So I'm not going to go into that, because they're now very cost effective and easily available. And good protocols have been made both by IHSTM as well as MOTA and NHM for the treatment and management of patients. Teleconsultation can be leveraged, and we now have very many centers of excellence that are now coming up for management. We do need to realize these patients need to be treated in all their different stages of life, right from childhood, pregnancy, and old age. And if we are able to support these patients and give them the healthy requirements that they need, they can have a very productive life. In order to reach patients in the remoter areas, telemedicine is something that should definitely be leveraged. And then integration of Ayush and sickle cell is something that the government is definitely looking at. And this would be very interesting to see how other Ayush systems can help these patients. Um, all the patients needs a lot of psychosocial support, and that again is due to can be facilitated through adequate training, so that the ASHA members and all of the other ANMs and all can give good counseling, but also different NGOs can contribute to this very important endeavor and provide support. Rehabilitative care is there. As you all know, there have been new guidelines that have recently come out in March of this year, 2024. And these will be providing permanent certification for disability for persons with sickle cell disease. And this will benefit them in education and reservation in colleges. So the new scoring system is very simple. It is not based on a lot of tests, because what was happening was the children in villages and remote areas were unable to get the sickle cell disability certification, which they really needed. And so that's why we have now made it a very simple scoring system. And if there's any questions related to that, I'd be happy to answer. So the National Sickle Cell Elimination Program has also got a web portal, and they are using that to identify patients, and they're also using that for providing a lot of different information. There are also many other groups that are joining with the government, either to do IC activities or to do camps or counseling for lifestyle, and even vaccination, vocational support, and genetic counseling. So young people can definitely get linked into this. And we know the community awareness is also very important, and people can create their own ABA ID. They can integrate with the web portal, and they can do a lot of research, and they can also use this for the mass media. So these are some of the very important steps that are being done. The delivery of the program in the different districts is very important, because not only will this provide service to the patient close to where they live, but also help in documenting the data by having a district-wide maybe setting up hospitals and for doing other things. So the web portal is really important. There's even a mobile app which patients can use, they can put in their reports, and they can get some important information on where they can go for treatment. So in summary, there's no easy solution, but I think we've made the first steps on this journey. It's a long journey. We have to connect these patients. The last mile, it should actually, I think, be the first mile, because that's the most important step, is to connect the patient to a healthcare provider somehow. We have a wide geographic distribution of sickle in our country and a very large population. I think these are older numbers. Maybe the numbers are much older, much larger now. And we have states where the prevalence is really, really high. So these are actually really important healthcare problems. And unless we work together, we will not be able to help these patients, and we will not be able to reach the target that we have. So with that, I end, and I'm happy to take any comments and suggestions. Thank you so much.
Thank you very much, madam. I would like to invite the questions from the house. Anshika, any questions from the online team?
No, sir, not yet.
Okay. Any questions from the hall? Yes, sir.
Good afternoon. This is Dr. Shivaji Kumar. I am the State Commissioner for Person with Disability. Just I want to know, like we are facing in the Bihar about the detailed guidelines of the certification. As we know, under the RPWD Act, the blood-related disorder, it is also comes under disability, and for making the disability certificates. So we want to know any guidelines, because the percentage of after 40%, 60% up to this. And now there's a UDID card also. So online web portal, we can apply also. So just if you can elaborate on that, if any guidelines are there for making the disability certificates. So we can use in our Bihar also.
हाँ जी, नमस्ते. सो आपका सवाल बहुत अच्छा है. सो अभी नए गाइडलाइंस निकले हैं मार्च में, अभी 12 मार्च को. So we have completely new guidelines, which are a revision of the old guidelines. The March 12th, 2024 Gazette of India has completely new guidelines for thalassemia, hemophilia, and sickle cell. We have made it very simple. बहुत ही हमने सरल बनाया है. So in order to get a 40% disability certificate, all you need is a diagnosis of sickle cell disease. So if you have your HPLC report, or if you have any other documentation, that is sufficient. The scoring is very simple. If there the scoring is only required if there are additional complications. Otherwise, if a person, even if they have no other complication, they only have a diagnosis of sickle, they will get a certificate of 40%. So please look at the Gazette of India, March 12th, 2024. All the guidelines are there. The UDID portal is currently being updated. Updated. I have been told by my discussion with the Department of Social Justice and Empowerment that the UDID portal will be in 1 month. So I think you'll have to wait till July. Then you can do the new UDID certificate by the portal. Thank you.
Thank you, madam. Any other questions? Yes, doctor. You can introduce yourself first.
Good afternoon, ma'am. I'm Dr. Surbhi Sethi. I'm a senior consultant with the National Health System Resource Center. Thank you so much for giving a very comprehensive overview of the guidelines. I wanted to understand, ma'am, from your vast experience, how can we further strengthen the guidelines, and if you feel some important aspect is missing from the public health perspective, I would just like to get some inputs from you on how you feel we can further strengthen these guidelines.
Thank you. See, I think on paper, the guidelines are really good. I think where we always fail is when we start implementing it. And I think the last mile is really the most tricky area, because if you go to the villages or you go to the tribal areas, often the PHC staff may not be very aware. The facilities vary quite a lot at the PHC depending on which state you are at. The PHC doctors will have PHC, CHC doctors will have a lot of programs to do, but that's really where I think the focus should be. So rather than working from the tertiary care strengthening, we need to look at the last mile. I think that's really where the focus should be. At the tertiary care centers, building more tertiary care centers, I don't think is really what is required. I think one, we need to get out there to make sure that every sickle cell patient, one, gets identified, and two, gets basic treatment as early as possible. And if we can take care of that, we are doing things the right way. Otherwise, trying to do transplants or trying to do gene therapy and doing higher managing complications, that's going to be a never-ending thing, like I say. But otherwise, it's a very well-designed, a very thought-out program, and I don't think I can add anything to that.
Yeah.
Actually, we have a few guidelines also available today also. We have a Indian College of Hematology and ICMR guidelines, which is they are very extensive. I have shared the copy, soft copy also. We have Indian Academic of Pediatric guideline on sickle cell disease. We have a Government of India NHM guideline on sickle cell disease. There are three very vast. They have discussed all the components starting from the. You have few international guidelines also. You have US government of guidelines also. They are available online. It's about 500 pages. It contains everything, and you have American Society of Hematology guideline also. So if you want to really know everything, so enough data are available online.
Thank you, sir. Madam, there is a question from online audience. Kanta Devi Arunachalam has asked where I can get details of prevalence in each state.
Okay, so see, the most of the states will have their own portal, and they will be able to give you that. You could also write to the Ministry of Tribal Affairs of the patients who are currently identified, but there's still many patients that we don't have data, but state-wise data.
The connection was slightly disturbed. If you do not mind, can you repeat the answer, madam?
Sorry. Oh, I was saying that the Ministry of Tribal Affairs is where you can contact and get the latest data.
Thank you, madam. So with this, if there is no more question, then we move on to the panel discussion. Of course, that will be moderated by madam again. And for the panel discussion, I would like to invite stalwarts working in the field for a long time. One of the pioneer is Dr. Ravindra Kumar Jaina from Cuttack. And I remember, I think in 2016 we met, and sir was planning to organize World Congress on Sickle Cell in 17. And sir has been working for years, and recently sir has been nominated as member of International Sickle Cell Hub on behalf of Southeast countries. So Dr. Jaina, please. Then on the panel, I am inviting Shri Gautam Dongreji. Gautamji has been very active, working and secretary of NASCO, National Alliance of Sickle Cell Organization. Very dynamic person, travels extensively. Then Anil Khatri sir from Red Cross Ahmedabad. Is those slides? What is there? Then Mr. Lalit Pargi, SCD warrior, is a NASCO as executive member from Udaipur. Neha Verma from Raipur. Ruchita Patel from Gujarat, particularly from Valsad. And has Miss Naz joined from Chhindwara online? Just check her.
No, sir, she's facing some network issues. She will join.
Okay. So I hand over through Dr. Tulika Madam and request panel members to answer the questions from the podium for the benefit of online audience. And Madam will ask questions one by one so that people can come up on the dais and all. And Dr. Anil Kumar Tripathi from Lucknow, past president of ISHBT, he is not joined now. In some time during the day, he will be joining. Sir has given important update that he has been getting patients from Nepal border and those districts. So we will have important updates from him also. Over to you, madam.
Okay. So okay. So first of all, thank you so much, and we have such an eminent panel, and all of you have such rich and diverse information and data. I had prepared some questions, but I think rather than having, since we're not going to be able to do it like a panel, I think the experts can maybe just come up and maybe talk about what they feel is, you know, the step that they feel is really important that can be done to achieve this target of elimination of the burden of sickle cell disease. Can I invite respected Dr. Ravinder Kumar Jina to maybe first give his views on, because he's coming from a very important state, Orissa, which has already done some very good strategies. So what do you think, sir, is the most important strategy for your state to be done next?
So thank you, Tulika, for giving an overall very comprehensive and very clear-cut, very precise view of the overall scenario and sickle cell disease and what's the government initiative, because you are a part and parcel and very core member involved in the government strategies. So we have faced, because planning a strategy is something and someday different scenario, but when it is being educated at the field level, some new complications, new challenges really comes up. We have faced that also, and that has to be really incorporated. So it's a very huge challenge, a very over-ambitious project, that the sickle cell elimination program by 2047, you know, technically it has to, I hope it will be modified. It will be, you can't eliminate the sickle cell by 2047, maybe sickle cell control program by 2047. I know, I understand the region concern how it was kind, but I am sure in the due course it will be modified. Second point is that so far the screening test of sickle cell disease is concerned, we have a experience of few lakhs in the recently, etc. It's working. It's a sensitivity, because our center is also one of the center in Odisha to validate these rapid cut tests. It's working, and sensitiveness is quite fantastic. It's 99% to even 100% also. And second is it's cost effective also. Now we have seen the initial, when it was decided the quotation was even 200 rupees, then it came down to 80. In the last 2 days, even there was in Odisha tender, it is only say 44 rupees. So, and it is effective also. I validated it is 100% sensitive and accurate also. So that is why, but the challenge is that at the field level, it has to be executed and the data has to be entered in the portal, and covering the 140 crore population is a challenge. I am sure we should adopt a gradual and slow process of going and doing certain things, thereby we can control. This is one. This is the one aspect, because it's only knowing the incidents. Whatever the rapid cat test is there, they will give you the proper incidents or identifications of whether you have a sickle cell trait or sickle cell disease, like that. The second limitations of this program, which I always believe we have advocated in the government forum also, with the government of India, even the Minister of Tribal Affairs also. If you do only sickle, we miss the other hemoglobinopathies like thalassemia, hemoglobin E. So the primary objective is preventing the birth of any disease hemoglobinopathy is being defeated. As you know, as for example, if you miss the beta thalassemia trait or hemoglobin E trait, if they marry with the sickle, the same problem the child is going to born with the even disease also. So I firmly believe that other hemoglobinopathy like thalassemia, hemoglobin E should be integrated, which I am sure the government of India, they have accepted also. Probably they have allowed the registration of the thalassemia and other hemoglobinopathy in that same sickle cell portal. Though now what I heard from the your Harsh Mangla also. Now the third point which I always think that not only the confirmation test, suppose every program has to be integrated because India is a very vast country. You cannot go a sickle cell program for 140 crore population. Again, thalassemia program for the 140 crore population, etc. So it makes a sense. If it is self-related, it has to be integrated with the same people, same logic, so we can achieve. And my last point is that these are not going to prevent. The prevention can be done by by prenatal diagnosis or by bone marrow stem cell transplantation or by gene therapy. So pending to the availability of gene therapy, I am sure which is not coming up in 5 years. Even if it comes, the logistical it will be very, very challenge also. Transplant and the prenatal diagnosis. I firmly believe that the scope and the facilities of the prenatal diagnosis, which we have done, we have started in Cuttack, we have done say more than 200, more than 300 now also. So the facilities of the prenatal diagnosis, which includes the chorionic villus biopsy, as well as also the genetic studies, should be available in every state, in different part of the state, so that a pregnant female don't have to travel about 500 kilometers or 600 kilometers to avail this one benefit. So if this will be available, which the government of Odisha has taken, we have declared that in 10 centers it's going to available. So these for prenatal diagnosis, I think a female or a partner will give an opportunity to have a healthy child. And so the last which I have a skepticism that the antenatal diagnosis or marriage counsel is a failure across the globe. Suppose you identify and screen the population who is a carrier of sickle cell or beta thalassemia. If you advise them avoid marriage among the carriers, you let me know how many people in this audience, if you know that a girl or boy is having a sickle cell or thalassemia carrier, he is going to marry. If it is an arranged marriage, so he is not going to accept the marriage. So prenatal, so these are marriage counsel or screening of the college going children, etc., and advise him to marry to avoid marriage. It's a failure across the globe. So what we should adopt that, we should tell that you can marry with each other, know your status, and take the advantage of the technology of the prenatal diagnosis so that you can have a healthy child. So that should be our approach. If you put a rider that you should not marry among the carriers, then nobody is going to declare, and there is a huge social stigma. That's the practical experience which I have done. I have changed my strategy. Earlier I was telling when in my earlier period of hematology that go for the hemoglobin matching before marriage, but that's not really becoming effective and accepted. It's a failure across the globe. Our approach is that marry with any girl or any boy, know your status by your screening test, etc., and take the advantage of the prenatal diagnosis if required, if both the husband and wife are carrier, to have a healthy child. So these are my views, and once again thank you very much for your wonderful comments and your very overall comprehensive view which you have given the government initiative and perspective. Okay, thank you very much again.
Thank you so much, Dr. Jean. Your experience and expertise in this area are beautifully highlighted by the very important comments that you made. I'm sorry, I can't see the audience. Is Dr. Anil Khatri, sir, there?
Yeah, good afternoon, madam. I'm here.
Wonderful, sir. So your state is an exemplary state. I mean, I think Gujarat is the state that we all look forward to. And you have been doing such wonderful work in the state in thalassemia and now also in sickle cell disease. Looking at this program and looking at the experience that you have in Gujarat, what do you think is the next step that Gujarat should be doing in order to reach the target and to bridge any gaps that we have in this program in your state? So, because I think health being a state subject, I think it's important that we have targets that are state specific.
Yeah, thank you. Very important points, madam, you brought out. And Gujarat journey started very long back. In fact, later in the afternoon, I'm supposed to take a talk on scenario in Gujarat, where I'll talk more in detail. But specifically, the points you have emphasized right now, what we still lack and plan to go do ahead is, and which is very important from the perspective of a good control, is first of all the districts which have a huge burden. There we plan to do a universal newborn screening and put all the identified newborns into proper care, because ultimately we see the burden of sickle cell diseases of complications, the crisis, the hospitalization, and so very important that every newborn, probably why not integrate, being I am a pediatrician, so I am always passionate about newborn screening for other inborn errors of metabolism also. But in our country, till the stage is arrived, well, we probably screen every newborn for other metabolic disorders also. At least for sickle, we have to start with a newborn screening, which should be universal, irrespective, we have, divided categories into less than 15% and more than 30%. So grade A, B, and C, D. But irrespective of that, I think every newborn, and now we are getting cheaper tests. So I think we should straight away go for a newborn screening. All identified newborns should be straight away put on proper channelize their care. Regarding management of these patients, every patient has to be linked to a health center. Maybe the primary health center where he resides, but it's a tribal population, and the challenge with the tribal population is a floating population. They will migrate to the place where they get work. They are most of them laborers. So that this is a huge challenge, linking them to a particular primary healthcare center. But unifying the care with a UDID portal, maybe I think even if the patient visits any part of the state, his basic data will be there. And we have a system. We have 160 sickle cell counselors in the state since long. And these counselors are doing a wonderful work, because there has to be a bridge between the healthcare workers and the community, the sickle cell sufferer, sickle cell patients. And these are the locals who are not educated. So local counselors who know these patients and their families very well serve a very important link, and I think it's a model which every state should take up, because there are so many national programs, and to expect everything from the medical officers and the paramedical staff there and ASHA workers, I think is asking for a moon. So there has to be a bridge in between. The bridges can be the NGOs. Of course, NGOs have a great role. In Gujarat, we have had wonderful experience of NGOs contributing to the implementation of this program. But these counselors will be very important. Then regarding pain charts, every patient should have a pain chart, so that you know the level of crisis they get during a period of year, and accordingly that can be modified. Then we need to have HbF levels. Of course, all should be put on hydroxyurea, but periodic HbF levels would let us know whether that hydroxyurea is working well or not. So, and more than that, of course, in Gujarat, we are blessed to have a tremendous network of blood banks. There is no district which does not have a component supplying blood bank. And still we are improving on that. But in the national perspective, I think it will be very important to, although the guidelines are there, but the medical community is also not aware about the rational use of blood transfusion in sickle cell disease. And most important, to prevent immediate deaths, we have to look upon our tertiary centers where we should have facilities for exchange transfusion. So I think there is the role of all hematologists, local healthcare medical officers, along with NGOs, and of course now with the government taking a very strong stand and a very good political will to go ahead. I think the future should always be very bright for all the sicklers. On the prevention aspect, I concur with Dr. Jaina on most of the things, but I like to differ on a thing, because Gujarat, we are so advanced and we are doing it for so many years, and still we feel that the work is so much incomplete. I'll share the data late in the afternoon, how many lakhs of tests we have done, 8 lakh pregnant ladies we have screened, but still we feel that we are lagging a little bit, and to avail of prenatal diagnosis in every nook and corner of the state is a huge challenge. And I think 2047 also would be a very far goal to achieve that. So till that point, I think pre-marriage testing and counseling is also very, very important in our country, because uh, still we see in many states there is not 100% registration of pregnant ladies. There are still home deliveries going on. So what about those? Those will be definitely missed. And regarding what Dr. Jaina said, I concur that we should not miss on an opportunity to diagnose thalassemia also. And when some patients have both the traits, so an integrated program for all hemoglobinopathies will be very important, because at the same time we don't want thalassemia to suffer. And I'll share that everybody knows in the country how the level of care for thalassemics has gone up. I think patient societies have played a great role, because the demand for better care has always been taken up by the societies spread across the length and breadth of the country. These are patient societies, of course, with the support of their treating doctors and other NGOs and the government. But this is one thing which we are lacking in management of sickle cell disease. So there will be a great contribution if these patients get together in their own districts or smaller places, form their own societies, look at their own problems, and demand for it. Because availability, once it happens easily, sometimes it is not valued. So it has to be both ways. Government going ahead few steps, at the same time the patient also needs to come ahead for few steps and demand things, so that we have a very perfect system going on despite the policy. So these are my views, ma'am.
Thank you. The extensive and wonderful work you've done in Gujarat has been highlighted. And I think the counselor is a very important post that many states may not be having. And I think we must learn from the experience that you've had. So that was very nice. We also have Dr. Anil Kumar Tripathi, sir. Is he there?
No, ma'am, he has not joined yet.
Ruchita? Dr. Ruchita? Is Dr. Ruchita there?
Yes, ma'am. Yes.
Hello.
Hello.
Hello. Wonderful.
Good afternoon, ma'am.
Thank you. Thank you so much. You are also from Gujarat, I believe.
Yes, yes, ma'am.
Would you like to add anything? I think is a very important thing that has to be done in order to help our patients with sickle cell, either for awareness or diagnosis or treatment?
Ma'am, awareness is very much important, play a very much important role. So I am from Valsad. So वलसाड़ में अवेयरनेस के लिए ज़्यादा सब हेल्थ काउंसलर को अवेयरनेस की बहुत ज़रूरत है, क्योंकि हेल्थ सेक्टर में अवेयरनेस के लिए ये पेरिफेरी में, मैं जहाँ से आती हूँ वहाँ से पेरिफेरी में बहुत सारे गांव में पेशेंट्स को ट्रीटमेंट तो मिलती है, लेकिन पेशेंट्स आर नॉट कमिंग टू टेक अप ट्रीटमेंट. सो वहाँ पे हमें गांव में जाके अवेयरनेस करने के लिए बहुत ज़रूरी है. और एक्सपेक्टेड कपल्स को स्क्रीनिंग की बहुत ज़रूरत है, क्योंकि जो ट्रेट होते हैं तो ट्रेट वो शादी करते हैं तो उसकी लाइक इन माय फैमिली माय फादर इज़ आल्सो सिकल ट्रेट एंड माय मदर इज़ सिकल ट्रेट. So I have SS pattern. My grandfather was also diagnosed as sickle disease, and he was the longest living at the age of 81 years. So due to great facilities available in Valsad and Gujarat, so we are living a good life. But I want more patients to benefit from this. So I would like to take government for awareness and expected couple screening, neonatal screening. So these are the major role.
आपके वलसाड में डॉक्टर इटालिया सर हैं.
Yes,
तो
yes.
वो तो बहुत सालों से बहुत अच्छा काम कर रहे हैं. पर एक बात बताएंगे बेटा, ये जो आप कह रहे हो कि बहुत सारे पेशेंट ट्रीटमेंट के लिए नहीं आते हैं, तो उनके मन में क्या है, वो क्यों नहीं आते? उनको लगता है फायदा.
Because of there is a lot of social stigmas in our Gujarat, in periphery areas. Like बेटी है तो उसकी शादी नहीं होगी, अगर हम लोग बता देंगे
कि सिकल ट्रेट है, सिकल डिजीज़ है, तो किसी को बताना नहीं है. Like social stigmas are still there. Even if well-educated families were also like कि ये बीमार बेटी है तो हम क्यों उसे बहू बनाएं. ओके. एंड वहाँ पे एक और स्टिग्मा भी है कि हम लोग राइस की रोटी खाते हैं, मतलब जैसे गेहूं की रोटी आती है वैसे राइस. तो वहाँ पे पेरीफेरी में आहवा डांग वैसी है, वसावा चौधरी वो सारी पीपल है ट्राइबल में. तो वो लोग ऐसे मानते हैं कि चोखा की रोटी खाने से भी सिकल सेल होता है. तो ये सारे स्टिग्मास बहुत उसको दूर करना बहुत ज़रूरी है, अवेयर करना बहुत ज़रूरी है. और डॉक्टर यजदी इटालिया ने ही मेरे दादाजी का डायग्नोस किया था एट द एज ऑफ 38.
So nice, so nice, so nice to hear from you. And ये आपने बहुत important हम लोगों को बताया डॉक्टर्स को कि हमें काउंसलिंग में भी बहुत केयरफुल रहना चाहिए, क्योंकि अभी भी लोगों के मन में ये ख्याल है कि अगर कैरियर है या कुछ तो हो सकता है शादी ना हो. सो डॉक्टर जीना ने भी ये हाईलाइट किया था और आपने भी. थैंक यू बेटा, थैंक यू सो मच.
Dr. Tulika, can I, Dr. Tulika, Dr. Jena here again. So I will come up a very, very quick point. Dr. Ruchika has raised it.
Yes, yes.
Actually, she has raised a very valid point which I missed, that the social stigma. I am certain there is no second opinion to that. Sickle cell disease carries a massive social stigma across the country. Unlike the thalassemia, hemophilia, because you can't hide this disease. Thalassemic has to come to the again for blood transfusion. Hemophilic has to come to the hospital. But some or other sickle cell disease has a social stigma. As she has told that probably I have done something wrong in my past, the God has caused, etc., etc. Not only the tribal population, man, forget about the tribal population. I have patients with the cabinet minister, IAS officers. उनका जब हम पहले देख कर आऊँगा, the first will tell, Dr. Jena, don't tell to anybody, even including my doctor also. You are an exception. I have doctor patients that told, नहीं sir, हमको नहीं बताना. When I requested them to lead from the front also. So social stigma is a big challenge. That's the reason I told you. The marriage counseling, telling them, tell me in the audience, I asked this question. If you are a youngster, if you are actually given to choose a marry a normal girl or with a career girl with career, how many will come up to marry a career? It's a failure across the globe. So as she has rightly told you, we have to take the precaution to destigmatize this. Sickle cell disease. So for my opinion goes, unless and until you provide the holistic healthcare services, the technological advances across the country in a uniform way, equitable way, every patient living in the country, in every part of the country, he should have confidence that yes, at my locality, I will get the best of the healthcare services, equitable services. If a sickler will feel with confidence that I have a accessible, equitable and a holistic services, I can lead a normal life, I can marry, I can have a children by taking the help of the technology, or I can avail the transplant program if required. Then only she can tell, yes, I am normal person, I am ready to declare. Unless and until we fulfill all these things, mere screening and doing all these things is not going to eradicate the huge social stigma which is inherited with sickle cell disease at present. You have raised a very valid point, actually.
Very nice, very nice. Thank you so much. Mr. Lalit Pargi from Udaipur, sir. Are you there? Thank you so much.
हेलो मैम. हाँ मैं यही हूँ.
हाँ, सो नमस्ते. सो नाइस टू सी यू. आप अपना थोड़ा सा बताना चाहेंगे अपना अनुभव, और आपको क्या लगता है कि सरकार को और क्या करना चाहिए राजस्थान में सिकल सेल के लिए?
जी मैम, थैंक यू मैम. राजस्थान गवर्नमेंट वैसे तो बहुत ही अच्छा वर्क कर रही है अभी, बट ज़रूरत है मैम, जैसा रुचिता जी ने बताया, सर ने बताया, अवेयरनेस मोस्ट इम्पोर्टेंट है. जनरल पॉपुलेशन में तो यही है, साथ में हेल्थ केयर जो प्रोफेशनल्स हैं उसमें भी बहुत ज़्यादा ज़रूरी है, क्योंकि मैं एक जीता जागता उदाहरण हूँ. मेरा जो डायग्नोस है वो काफ़ी लेट है. मैं सिकल सेल वॉरियर हूँ. 16 साल की एज तक तो मुझे पता ही नहीं था कि मुझे सिकल सेल है. जो मैंने पेन सहा है, तो मैं अभी तो काफ़ी मतलब अभी जिस तरह से हमारे स्टेट में 60 से 70% तक स्क्रीनिंग जो हमारा इस साल का टारगेट है वो पूरा कर लिया है ऑलमोस्ट, बट कुछ चीज़ें हैं जिन पे थोड़ा फोकस करने की ज़रूरत है। जैसे बताया कि सिकल के साथ बीटा थैल हमारे वहाँ पे मोस्ट कॉमन है, तो उसके लिए भी थोड़ा कुछ मतलब स्क्रीनिंग जिस तरह से हो रही है, स्क्रीनिंग तो हो रही है उसमें कोई शक नहीं है, बट उसमें ऐड करने की ज़रूरत है कि जैसे बीटा थैल है तो उसको भी स्क्रीन करना चाहिए साथ में, क्योंकि वो अगर स्किप होता है तो कहीं ना कहीं आपका जब JCID कार्ड बन के आया तो आप अभी जो आपकी स्क्रीन होगी उसमें तो आ नहीं रहा है वो। जैसे ही आप JCID कार्ड है वो मिलाएंगे एंड देन उसमें तो नॉर्मल हैं आप, और एक बंदा अगर सिकल है और दूसरा नॉर्मल है, एंड देन जब बेबी आता है नया, फिर उसमें सिम्टम्स आते हैं, फिर हम HPLC के लिए जाएंगे तो तब पता चलता है कि सिकल विद बीटा है इसको। तो मैम हमारा मिशन है वो कहीं ना कहीं मुझे ऐसा लगता है कि हम वापस से जीरो पे आ जाएंगे अगर इस तरह से होता है तो। और अवेयरनेस बहुत ज़्यादा जरूरी है, सबसे इम्पोर्टेंट तो यही है मैम। जी मैम।
थैंक यू। सो बहुत अच्छा लग रहा है कि राजस्थान में इतना अच्छा काम हो रहा है, बट अभी काम करते रहना है और अभी अवेयरनेस और बढ़ाना है। थैंक यू सो
जी
मच। थैंक
थैंक
यू।
यू मैम।
नेहा जी है, नेहा वर्मा रायपुर से।
No, ma'am, he's not there. She is not there.
ओके, स्वलेना नास, स्वलेहा
No, ma'am, she is also.
छिंदवाड़ा से। ओके ओके, गौतम जी हैं फिर, गौतम डोंगरे जी। सो द वर्ड इज योर्स सर।
नमस्ते
तो
मैडम।
गौतम जी नमस्ते। तो आपको तो पूरा सिकल सेल के बारे में सब कुछ मालूम है, बस अभी ज्यादा टाइम नहीं है, पर आप मुझे दो दो तीन चीजें बता दीजिए जो आपको लगता है कि गवर्नमेंट की तरफ से अभी भी कमी है, या आपको लगता है कि अभी नेक्स्ट स्टेप में ये होना चाहिए।
फिर से धन्यवाद मैडम, और मैं धन्यवाद करना चाहूँगा डॉक्टर पेंढारकर सर को कि उन्होंने हमें इनवाइट किया, यहाँ उपस्थित मंच और सामने उपस्थित सभी एक्सपर्ट्स और ऑनलाइन उपस्थित सभी लोगों को हमारा नमस्ते। मैम मैं पहले बता देना चाहूँ कि जो ऑडियंस है उन्हें भी कि मैं एक पेशेंट ऑर्गेनाइजेशन की तरफ से हूँ, और पेशेंट पेरेंट ऑर्गेनाइजेशन जो नेशनल अलायंस है यूनेस्को, ये पूरे देश में सिकल सेल अवेयरनेस के लिए अपना सरकार को एक सपोर्ट कर रहे हैं, ताकि ये हमारी सोशल रिस्पॉन्सिबिलिटी समझ करके हम इस पर काम कर रहे हैं। मैडम जो दो तीन चीज़ें आपने कहा है, जो मुझे एज ए नेशनल पर्सपेक्टिव सिकल सेल का पेशेंट्स का जो नीड हमें समझ में आ रही है, वो दो तीन चीज़ें ये है, जिसमें सबसे प्रायोरिटी है कि प्रोफेशनल हेल्थ केयर प्रोफेशनल्स इन लोगों का ट्रेनिंग रिगार्डिंग सिकल सेल डिसीज डायग्नोसिस और ट्रीटमेंट, ये सबसे फर्स्ट पार्ट है मैडम। क्योंकि हमारे पेशेंट्स आज भी सही समय पर डायग्नोस नहीं हो पाते, और सही समय पर डायग्नोस नहीं हो पाने से अर्ली डेथ्स हो रही है, कॉम्प्लिकेशंस हो रहे हैं, एवियन हो जाते हैं, और 15 से 20 साल की उम्र में ही हैंडीकैप हो जाते हैं क्योंकि उनके हिप जॉइंट्स ख़राब हो जा रहे हैं। ये सारी चीज़ों के कारण है कि अर्ली डायग्नोसिस नहीं है। तो सरकार जो कि सिकल सेल मिशन लॉन्च किया है उसके लिए हम लोग सभी धन्यवाद देते हैं, और इस मिशन में सरकार के साथ हम सभी लोगों का भी एक सहकार्य होने की ज़रूरत है, जिसमें सारे स्टेक होल्डर्स मिलकर काम करेंगे तो बिल्कुल हम इस मिशन को एक कामयाबी के स्तर पर पहुंचा सकते हैं, बहुत कुछ कंट्रोल कर सकते हैं। तो इजी कंट्रोल है, क्योंकि हमें लोगों को बताना है कि आप शादी के पहले सिकल सेल टेस्ट करें, और अगर अनफॉर्चुनेटली सिकल सेल वॉरियर आते हैं तो हमें प्रोफेशनल हमारे तैयार होना चाहिए, उनको पूरा पता होना चाहिए कि कैसे जो जो ट्रीटमेंट प्रोटोकॉल्स है उसके थ्रू वैक्सीनेशंस है, बाकी सारी चीज़ों को दे करके उसको फुल लाइफ का एंजॉय, उसको पूरी ज़िंदगी जीने के लिए मदद कर सके। साथ ही सबसे सेकंड जो इशू हम लोग अभी पोस्ट स्क्रीनिंग देख रहे हैं, जो सरकार ने बहुत तेज़ी से शुरू किया है स्क्रीनिंग, जिसके लिए धन्यवाद फिर से देंगे। स्क्रीनिंग के साथ अवेयरनेस इम्पॉर्टेंट है, जिसका थोड़ा अभी हमें अभाव दिख रहा है। तेज़ी से स्क्रीनिंग तो हो रही है, किंतु साथ में जब हम बताते हैं कि आप एएस है या एसएस है, तो उनकी काउंसलिंग भी ज़रूरी है कि एएस यानी क्या, आप सिकल सेल कैरियर है, आप ट्रेट है, आप डिसीज़ नहीं है, ये उन्हें बताना बहुत इम्पॉर्टेंट है। मैंने काफ़ी फ़ोन कॉल मैडम रिसीव किए हैं, क्योंकि हमारा नेस्को का यूट्यूब चैनल जो कि सोशल मीडिया में है, काफ़ी लोग सिकल सेल के बारे में सर्च करते हैं तो ढूंढकर हमारे वीडियोस में विज़िट करते हैं, फिर नंबर देख करके हमें कॉल करते हैं। तो कॉल में आजकल ये आ रहा है कि हमें बोन मैरो ट्रांसप्लांट कराना है। मैंने कहा बहुत अच्छी बात है, तो आप अपना HPLC भेजिए, मैं डॉक्टर से कंसल्ट करता हूँ। HPLC भेजते हैं तो वो ट्रेट निकलते हैं।
ओके।
तो ट्रेट अभी समाज में ये पता नहीं है, जब मैं उन्हें पूछता हूँ आपको कोई सिम्टम्स है क्या, आपको कोई क्लिनिकल प्रॉब्लम्स आ रही है क्या बचपन से, नहीं 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 बोले, हमारा टेस्ट हुआ है, हम सिकल सेल ट्रेट हो गए हैं। तो सिकल सेल ट्रेट मीन्स उनको लग रहा है कि हम डिसीज़ हो गए हैं, और वो सर्च करने गए हैं, अभी सोशल मीडिया में गूगल्स में सर्च कर रहे हैं, तो उसका एकमात्र इलाज बोन मैरो दिखता है, और वो बोन मैरो के लिए इनफैक्ट परिवार रो रहे हैं। यानी ये एक थोड़ा पोस्ट स्क्रीनिंग इफेक्ट है, मैं इस माध्यम से बताना चाहूँगा कि क्योंकि इसके साथ अगर अवेयरनेस साथ में नहीं होगा तो ये अलग स्टिग्मा पैदा करेगा कि हमें सिकल का लेवल हो गया है। जिससे रुचिता जी ने कहा है शादी नहीं होती, तो ये बहुत बड़ा प्रॉब्लम है कि सिकल अगर हमने बताया तो शादी नहीं होती। तो ये सेकेंड थिंग है, पहला हेल्थ केयर प्रोफेशनल, दूसरा हम स्क्रीनिंग के साथ अवेयर जब तक नहीं करेंगे लोगों को कि ये डिसीज़ एसएस डिसीज़ है और एएस तो एक कैरियर है, वो अपने आप में एक नॉर्मल व्यक्ति है। ये दो बातें बहुत इंपॉर्टेंट है। तीसरी अहम बात है मैडम कि अगर हमने एसएस डिटेक्ट कर दिया तो उसको लेबल लगा के छोड़ नहीं देना है, हमें उसको प्रॉपर ट्रीटमेंट का गाइडेंस उसी स्पॉट पे मिलना चाहिए जहां हमने उन्हें स्क्रीन किया, क्योंकि उसके बाद वो डिस्ट्रिक्ट हॉस्पिटल नहीं आएगा। तो हमें वहीं पर बताना है कि अगर आप एसएस है तो हाइड्रोक्सी यूरिया अवेलेबल है, इससे आपकी ज़िंदगी पूरी नॉर्मल हो जाएगी। आपको वैक्सीनेशन करा लेने हैं, न्यूमोकोकल वैक्सीन ले लेनी है, बाकी की जितने भी वैक्सीनेशन है वो लेने हैं। आपको पानी समय पर पीना है, ज़्यादा पीना है, आपको ज़्यादा एक्सट्रीम वातावरण में नहीं जाना है। तो ये सारी चीज़ें अगर उसको स्क्रीनिंग के दौरान मिल गई तो हमारा मिशन सक्सेसफुल होगा। अदरवाइज हम सिर्फ लेबल करेंगे तो सिर्फ स्टिग्मा फैलेगा। तो ये तीन चीज़ें आज के माध्यम से मैं सरकार तक भी पहुंचाना चाहूँगा कि ये अवेयरनेस जनरल पब्लिक और प्रोफेशनल्स के साथ सिस्टम में भी बदलाव हो, कि सिस्टम में तुरंत उसको वहाँ पर ट्रीटमेंट मिले। जैसे कि डॉक्टर पेंडारकर सर कह रहे थे कि हम हमारे ही जो सिस्टम को स्ट्रेंथन करें, उनको एजुकेट करें, ताकि उसको जगह पर ट्रीटमेंट मिले और वो फुल लाइफ एंजॉय कर सके। मैडम ये तीन बातें मुझे आज के सिनारियो में लग रहा है। थैंक यू सो मच।
बहुत बहुत धन्यवाद, आप बहुत बढ़िया काम कर रहे हैं इस क्षेत्र में, और कई सिकल सेल वॉरियर्स और सिकल सेल ट्रेट लोगों को आपने काउंसिल किया है। थैंक यू सो मच। And with this, I hand over to the organizers, and I want a big hand of applause for all the excellent panelists and all their very valuable comments. Thank you so much. And back to the organizers. Thank you, Dr. Pendharkar, for this opportunity. Thank you, sir. Yes, sir.
Hello, ma'am. This is Dr. Prashant. No, so, ma'am is around. Meeting is ended.
So she is.
Okay. So thank you so much. Thanks to all panelists, Dr. Jena, Dr. Dongre, and everyone. I think it was very wonderful brainstorming. And to conclude, I think the summary was, the screening program is going very aggressively, but along with that, HBE and thalassemia should be also screened, because that was the one take-home message which I could find from most of the speakers. So I think, the government will take call on this, that, how to include HBE and thalassemia in the sickle cell elimination mission program. So thank you so much. Thank you, everyone.
So I would really like to thank all the panelists for coming and giving their valuable time. And whatever we are discussing is being recorded by NHSRC. So NHSRC is an agency which actually makes the policies for the government, or which advises the state how to go about the problems. And their recommendation has really a big value. So fortunately, we have with us their experts. And Chair NHSRCC will be also joining us. He was supposed to be here physically, but due to some parallel meeting, he could not come, but he'll be joining us now virtually. So the aim of this program was really creating an advocacy amongst all segments of the society, be it a hospital, be it a college, be it a medical NGO, be it an institution, be it a government. So in all these ways, we really wanted to create the advocacy, which we have done. And I'm sure we will be able to really generate some document out of this and present this as a document to the state. Now our job is much easier because NHSRC is there. They will prepare a document, and it will really help all of you in fighting the sickle cell disease. So I'm just, so thank you very much once again. And I would request Dr. Kotwal to join. Is he joining? बात होगी डॉक्टर कोतवाल से, कनेक्शन हो गया? Yeah, please.
Sir, yes, sir.
So Dr. Kotwal has joined with us. Very, very senior physician, I would call him, because I'm a physician, so I would love to call people physicians, who is actually really has designed so many programs for the country, and really working and advising state also on this. So this is our main agency which helps us in planning all the programs, the health programs related to the country, planning, designing, execution. So we were very fortunate to have him with us today, and I'm sure he would really guide us on many aspects of sickle cell disease. Dr. Kotwal, sir, please.
Thank you so much. And am I audible, clearly audible?
Yes, sir.
Thank you. And I would like to place on record my gratitude and thanks to you and the entire organizing team for giving me this opportunity. And in fact, three of my senior consultants are already there attending it physically. And there's some, that there's a 10 days and 100 days programs for Viksit Bharat, and that's why we all are busy. In fact, a lot of people are there in my office, and we're having meetings since morning on with the ministry also. So that's why I couldn't, travel over there. So thank you for this, opportunity even to address through online. A very good afternoon to all of you, and I'm really happy to, see this CME on sickle cell disease. Because I'll share an interesting discussion with you what I had yesterday in Nirman Bhavan with one of very senior officials, who told me that the sickle cell disease, the program which you all are aware, I think Dr. Tulika Seth talked about that program also, National Sickle Cell Anemia Elimination Mission, which is there last year only. So about the sickle cell disease is now getting the importance it deserves, but historically, if you see in India, that what I shared with the senior official yesterday, I'm telling you that. But before that, how this conversation came up was that the important points of information, education, communication, and the other counseling part, that is what needs to be strengthened when we talk of the National Sickle Cell Anemia Elimination Mission. The testing has improved tremendously. There are targets even for that, of course, and that's why number of tests are there. There are various point of care diagnostic which are available, which is below 100 rupees now, and which was earlier not available as such. And of course, we are also planning now, to link those with the centers of excellence, create some new, strengthen existing aims and certain other institutions into center of excellence for sickle cell disease and subsequently for all hemoglobinopathies as such. So the 2016 guidelines, of course, you all are aware about the hemoglobinopathies, which also need some revision and updation, because in sickle cell we have made brought in new things which we need to now include for the entire, look at other hemoglobinopathies also and improve those guidelines. So this senior official told me that, for thalassemia, there's a so-called cure as such. I'm using their words only, that, a bone marrow transplant is there. Otherwise, here we are just giving hydroxyurea and we can just mitigate. We can't, I said there's a bone marrow transplant option available for sickle cell also. And of course, it is up to 15 to 16 years of age. Selection criteria are there, and of course the rate of failure and all probably slightly more, and availability of the donor also is sometimes challenging in the sickle cell disease. And, but I was that they have made this through experts of the Thalassemia Society of India. So that's where I started thinking. I had a discussion with a few officials of the ministry last evening, and even this morning, also independence onwards. The administrative authorities, the political, the ministers and all here, of health as well as the tribal, and also the senior officials, were mainly from the North India, and rest, very few in the hinterland. Sickle cell disease, I think, 10 to 12 years. So that's why there's a more importance of thalassemia and other hemoglobinopathies, and sickle cell disease was a tokenism which was going on. So this the even if you see the studies and all which show that range of 4 to 44% prevalence of sickle cell disease in those groups. And thalassemia, it is about, again, 3 or 4 to 17%. So so you see the magnitude over there, and actual burden. And somehow, philosophically, we all doctors, we thought that, that sickle cell trait prevents them from malaria. So instead of addressing malaria, we said just protecting them. So that's another, it's our way of thinking, which needs to change now. And luckily, we are controlling malaria. We are thinking of eradicating and all, but I somehow, as a public health specialist who have read in detail about the failures earlier of 70s and all, so that's why we keep on advising everyone that we need to be very careful, strengthen it further, because we think of elimination, eradication as such. So elimination is a good word which we use, because it allows some proportion, of course, of that disease to continue. That's the elimination targets as such from the country, because it may research it done like that historically over there. So that's why now it is time that we need to think of addressing this sickle cell disease, and the I would request all of you from clinical side. Although Dr. Dinesh mentioned about my being a physician, so yes, all MBBS are physician, but I'm a specialist in preventive medicine and an epidemiologist by training, and also working in the health programs, and now working with the Government of India for the health system while heading this excellent organization, National Health System Resource Center, being a think tank for the Ministry of Health and Family Welfare, and also working with the states to understand their implementation challenges, their successes, and also helping them in the implementation as such. Not implementing it ourselves, but also guiding them and helping and working with the states, and also learning from them and see how we can keep improving our policies and plans as such. So that's why it is now time, and it's an excellent program which the government has launched, and I'm not going into details of that because Dr. Tulika already has mentioned all the details about the actual disease that again we are still of the even this not only PHC even sub center Ayushman Roge Mandir, and we are given dispensing rights to CHO for this. Prescription of course is only by specialists and medical officer, but CHO can dispense it and regularly monitor. Now with the improved availability of diagnostic tests at sub-center and PHC and CHC and DH level, with a dedicated number of tests which we are requesting the states to do that, the availability of those doctoring are also available. If something is not available in sub-center, this is not the patient. The majority of the states are now put this sample transport system and all, some in PPP mode, some in the within the in-house as such. There are challenges in several areas, of course, where things are not happening on ground despite the effort. So that's where we are working with the states now to strengthen it. And again, the cards and all which are there, there's again that was the issue that should we give them cards and all.
Recording in progress.
Are are visible to everyone. People saying that even with this drug, the actual outcome is not. We need to now provide stem cell transplantation of selected cases. Then again, physician's role come in from very beginning. That's why we need to identify from very early and counsel to but of course we can't counsel people that effectively to prevent immunity to in totality and such. So some people will definitely take as such. And as the genetic disease week because this mutation will start taking place, move it. We all know those genetically all the treatment modalities to create a referral chain to
Recording in progress.
pregnancy and all. So that also can be. I hope I am audible, or have you?
The link
Hello?
is unfortunately just breaking in between, but it's okay.
Okay. Well, I got a call from one of my team members there. Okay. So this linkage with the RBSK and Anemia Mukht Bharat and that also is now important. So I would request all of you working in this field to also go to the field, go to the states, and happy to support you, and so that you can go part of along with implementation research on this. Please feel free to share your initial thoughts, initial ideas with us. We can together work and design some projects as such to see what new innovations we can bring about, and even how to strengthen the existing program, because we need more people who are ready to work in this field as such, experts, not who are in treatment as such and management. Even on ground when you go, it will be great help to the entire public health. Once you are part of the public health teams as such, the people who are looking at program, you can give your valuable inputs in that, and also part of the research projects and all also. And again, we all need to be very clear about that Rights of Persons with Disability Act of the Ministry of Social Justice Empowerment, BOSJ. That also I think you need to link them with the civil surgeons for the certificates, so that they get those certificates and enjoy those privileges as such over there. And of course the multi-stakeholder involvement, which I already mentioned, that you involve the NGOs and all who work with you for treatment. You can involve them for the So, also ensuring that this treatment is available to people in the remotest part, and sufferers are there in the country. So once again, thank you very much for this opportunity, and I congratulate the organizers for organizing this me on a very topic, which was hitherto neglected since last years. The importance is being given, and we hope that we are able to manage this and achieve target. But I think we're talking about talking.
I think the link was really very poor, unfortunately. But what Dr. Kotwal told us that we should come up with all the programs, give those programs to him so that the government can look at them and implement at a broader scale. So unfortunately, the link is cut down. So I would really like to thank Dr. Kotwal for joining us in and sharing his thoughts on sickle cell program. And we would really like to convey him the message from our team side that we are very keen that the government comes up with district sickle care program. We have already initiated this program in 3 districts of India, and we'll be very happy to partner with the country in taking this program to all parts of the country. We'll involve a team of experts from the country, and that would be our contribution to the country. Thank you very much, Dr. Kotwal. And I would like to thank everybody sitting here, and we would like to do a small ceremony of inauguration of this particular today's session. I would request our Chairman, Dr. Rakesh Gupta sir, to come on the dais. Dr. Rath, Dr. Gehlot sir, Dr. Jaina sir, Dr. Gautam, Lalit, Khatri sir. Photographer. फोटो बना रहे हैं नीचे कहाँ अरे सर नहीं है ठीक so I would like you to sir आप यहीं रुक जाइए डॉक्टर गहलोत सर इधर रुक जाइए प्लीज so we would on the occasion of this session, we would like to just hand over memento about the hospital to few of the experts who have come here. I would request Dr. Rath, Dr. Gupta sir and Dr. Gehrot sir to hand over the mementos of the hospital.
So I will invite Dr. Jaina sir first. Yeah.
So Professor Jaina is Professor of Hematology at Cuttack Medical College and devoted all his life to sickle cell.
Shri Gautam Dongre ji. He is Secretary in NASCO, National Alliance of Sickle Cell Organization. Very, very active and dynamic person. Dr. Anil Khatri sir from Red Cross Ahmedabad. Dr. Deenbandhu Sahu, Odisha.
I think he's outside. There is a video conferencing going on. So it's
Okay. Dr. Shivaji Kumar from Bihar. Dr. Ruchika Patel from Gujarat. Shri Lalit Pargi, SCD warrior, and he is also a NASCO executive committee member from Udaipur.
He runs Rajasthan Sickle Cell Society and Sickle Center in Udaipur. Yes, sir. So thank you very much. Thank you, everybody. Thank you, Dr. Gupta, Dr. Gehlot, Dr. Rath, sir. And thank you all for joining us today. So we are breaking for the lunch. And after lunch, we meet at
2:30.
At 2:30. Thank you. After this, after the lunch, we have a very important lecture by Dr. Jaina on what are the challenges in diagnosis. Let's go for the lunch. one disease, and biologically it may be different diseases. For example, what has been commonly reported is there are some SS homozygous sickle, then some sickle beta, then some sickle E, some sickle C, some sickle D, and if we start doing more tests, we may find some other variants also. We really do not know how clinically they are different between each other, but I'm sure if the number increases and if we start pulling all the numbers together, then things would change. So my request to all the sickle cell experts will be to create a repository of sickle patients who are not SS. Because yes, putting SS will be very difficult because the number is very large, but some clinical situation of heterozygous sickle, if we can put S, E, S, C, S, D or something else, then probably we'll be able to find out some different clinical presentations. Sickle in the Northeast is homozygous EE. Is different than homozygous SS in Odisha, Madhya Pradesh, Chhattisgarh. Is it clinically also different? Does it clinically require minor intervention or no intervention? What is the role of hydroxyurea? We don't know. It has not been studied in detail. There are reports, but they are reports on small number of patients. So probably we should create a repository of sickle cell patients who are not homozygous SS. Maybe NIC can create a website and people treating such patients can start registering such patients. So I would like to invite now Professor Gina on this diagnosis of sickle cell disease. You know, he has spent all his life on sickle cell disease, largest experience, largest data he has. So his insight would definitely help us. Dr. Gina, please.
Okay. So thank you and welcome to this afternoon session. At the outset, thanks to Dr. Pandarkar and his colleagues for inviting me to this very unique opportunity and unique platform to discuss about sickle cell disease, which is so close to my heart since long. So in the next few minutes, I have been assigned the responsibility of talking about overall view. It's a superficial view. I won't go to the depth of the pathophysiology and diagnosis of sickle cell disease and other hemoglobinopathies, considering the audience profile. So I'll go to overall superficial way of for just touching the pathophysiology and diagnosis of sickle cell disease. You know, the hemoglobinopathies are called the disorders of the hemoglobins. It can be broadly divided into two groups. One on the left side, you have a quantitative defects, means if the alpha chain or beta chains there is a less production, so we call it as a thalassemia. If the alpha chain is less, we call it as alpha thalassemia. If the beta globin chain is less, we call it as a beta thalassemia. Accordingly, we have a thalassemia minor, thalassemia major, so on. And here is the qualitative difference. Qualitative means the amount of the alpha and beta chain remaining same. If the structure of the beta chains, there is a variability or changes in the amino acid sequence of the beta globin chain, we call it as a qualitative. And under the qualitative, you have a hemoglobin E disease, sickle disease, and hemoglobin D disease. So in this way, so very simply, we can divide the hemoglobinopathies, which are genetic blood diseases, into quantitative or qualitative defects. Now let us, my job is to go for the sickle cell pathophysiology. This is, the sickle cell, there is a only single point mutations in the globin chain, in the globin gene. The beta globin chain is controlled by the beta globin gene. So beta globin gene having a 146 amino acids. So on sixth position, adenine is substituted by the thymine. So that is only one single mutations abnormality in the amino acids in the beta globin gene, which leads to abnormal beta globin chain. Means when glutamic acid is replaced by the valine at the position of the sixth in the beta globin chain. So therefore we call it as alpha 2 beta 2. The amount of alpha and beta globin chain remaining same. Here at the sixth position, glutamic acid is replaced by or is substituted by the valine. It is one of the biggest medical history of how one single amino acid mutation can give rise to such a profound clinical presentations varying from completely asymptomatic to symptomatic and sudden death. It's probably the biggest medical history, but that is how the pathophysiology stands as on many unknown things also, which cannot be explained so far the phenotype is concerned. The pathophysiology, the normal red cell is a biconcave disc whose diameter is 7 micrometers. When it passes to the circulation, it carries the oxygen and the nutrients. And the microcirculation, you have its diameter is 2 micrometers or even 3 micrometers or even 1 micrometer. So how a biconcave disc of 7 micrometer, it passes to these less diameter microcirculation? It is because the normal red cell is very flexible, malleable. When it circulates along the microcapillaries, it adopts the structure of the microcirculations or microcapillaries. So easily it passes out and it even delivers the oxygen and nutrients. So that's the normal function of the physiology, the normal function of the red cell, which is very, very important. What happens in sickle red cell? Because of the sickle red cell, it's a very rigid. It lost its malleability and flexibility. So while passing through the microcirculation, it cannot adopt the structure of the microcapillaries. So it stick to the microcapillaries, so it cannot pass. So it causes the obstructions or ischemia, which is being characterized by the vaso-occlusive crisis. And because of the sickle red cell, which is abnormal red cell and very rigid, as you know, the red cell survives up to 120 days. The sickle reds are being hemolyzed or removed from the body by the reticular endothelial system even less than 40 years. So precisely, vaso-occlusion are the microcirculations which give rise to vaso-occlusive crisis, most important clinical presentation, and increase the hemolysis of the red cell, which give rise to hemolytic anemia. Two sine qua non of the pathogenesis or two clinical presentations or pathophysiology, which explains the almost all the clinical presentations of sickle cell disease. So pathophysiology, as I have already told you, there is a beta globin gene mutations, which is a classic of the your sickle cell homozygous. As I told you, it causes vaso-occlusion of the microcirculations. I have explained the reason, which give rise to vaso-occlusive crisis. Even in clinical scenario, vaso-occlusive crisis, severe pain, there are many situations where there may not be vaso-occlusion crisis or overt pain, but still there is a subclinical vaso-occlusion of various organs, starting from your kidney, liver, heart, or brain, and your skeletal system also. So every organ can be affected. So it causes the chronic organ damage. So vaso-occlusion, when it is symptomatic, it gives rise to vaso-occlusive crisis. When it is subclinical, it can obstruct every organ. So you have a chronic organ damage. Every organ of the human body can be affected. And because of the increased red cell destruction, it can give rise to hemolytic anemia. In addition, they are prone for infection and vasculopathy. It's a chronic inflammatory vasculitis also. So all these things, vaso-occlusive crisis, chronic organ damage, hemolytic anemia, infections, vasculopathy, because of the inherited red cell abnormality, that explains the entire, in a very simplest way, the pathophysiology of sickle cell disease. It affects every organ of the body, starting from the brain to heart, to liver, to kidney, to skeletal, to skin and periaphysium. So almost every organ can be affected by the sickle cell disease. The main causes of the mortality are infections, acute chest syndrome, strokes, renal failure, pulmonary hypertension. They are the main causes of the morbidity. So if you look at the pathophysiology, it's not a single disease. It's not only one abnormality or one problem we can address also. You have a multiple patho abnormality happens. There can be abnormality in the circulated blood cells, means there is abnormality in the red cell, reticulocytes, neutrophil count are high, monocytosis, platelets, they are not only increasing in number, they have inherited adherence or their adherence, adhesiveness is increased also. Abnormality in the vascular endothelium, as I told you, vasculopathy, because of that you have endothelial cells, microparticles, extracellular matrix, endothelial abnormalities there. You have many plasma factors also, like your coagulation proteins are increased, fibrinogen is increased, inflammatory molecules, hemolysis products, soluble adhesion molecules, they all are increased. So it makes a sense that so sicklepathy or sickle cell disease is a conglomeration of these so many factors. So that is the reason why not a single drug may not be effective in all the cases. You have a multiple mechanisms affecting the circulatory blood cell, vascular endothelium and plasma factors. So that is another unmet medical need, because none of the trials like your acute leukemia or blood cancers, you have a multiple drugs are being taken into clinical trial comparison with your standard treatment. So what the need is there. In sickle cell also similarly, we should have drug addressing each component, combining the drug. Try in a sickle cell patient and compare with your standard care. Then only you can tell whether the optimum care of the patients or sickle cell patients can be established. So this is because of the multiple mechanisms. Finding a standard therapy or best therapy all the patients, it becomes a medical challenge. The factors contribute, as I told you, you have a huge clinical variability. One end you have asymptomatic, on the other end, in spite of best trial also or treatment, patient can have a sudden death because of the hemoglobin F. Higher is the hemoglobin F, it attenuates the sickle cell phenotype. So gene haplotypes, you have Indian, Arab, Senegal, Benin, Bantu, Cameroon, which are of African haplotype. The clinical phenotype varies. Alpha thalassemia mutations which are seen in Arab Indian haplotype, the vasculopathy or the vasculosis crisis increases rather than the hemolytic component is suppressed. And there are environmental factors also plays a very important role in the morbidity and mortality. It all depends on your social class, your financial status, infection, how able you are controlling infections, diet and climatic, and your day-to-day activity. These are all parameters that the social factors influences the clinical presentation. And to be honestly telling, there are many situations where you do not know the answer. Why in this case the severity is less or severity is more? So in many cases, we do not know the answer to explain the clinical variability. That's all about so far the pathophysiology is concerned. Now I will be talking on few things about so far the diagnosis is concerned. The diagnosis of hemoglobinopathy can be broadly divided into screening tools and then confirmation tools. On the screening tools, I'll go, the principle is that we have a solubility test, take a test tube, add certain things, solubility test. But in our recent experience, whatever we have done the soluble test, the false positive, the false negatives are very, very high, very cumbersome. So the doing it at the field level is very, very difficult. So it is abandoned. Nobody goes for the solubility test in the field level. Thanks to the government initiative, now we have a rapid CAT test has come. So the principle is you have a lateral flow assay or your competitive lateral flow. We have many commercial kits are available. We have tested in Odisha also. It's working very nice, easy, very quick. You can do it also. Sensitivity and specifics is very, very high. That's a great development so far the screening test is concerned. But this screening tests, they only capture the sickle, hemoglobin S, and they can differentiate between sickle cell trait or sickle cell disease, but they cannot differentiate sickle beta thalassemia or sickle cell homozygous or hemoglobin E or beta thalassemia. So that's the limitations of the screening test, because it has not been designed to capture the other hemoglobins. But so far the confirmation tool is concerned, other than the genetic study, I am not covering the genetic study. You have three types of the confirmatory tools. One is your HPLC, viroid variant. Second, your capillary zone electrophoresis. And third is your microchip electrophoresis by Gazelle. So these are the three equipments which are available so far the confirmations of this hemoglobinopathy, each having its advantage and also the limitations also. Solubility, these are the principle. I will skip it because it is not possible at the field level. It has been abandoned. Nobody goes for the soluble test. Now these are the, so for the rapid CAT test is concerned, you have hemotype AC. I will skip that. You have a Sickle scan, and you have a many Indians also. You have a, so Tulip company has done it. Now Transisi has done. Now Merrill company has done. There are at least 5 India-made rapid CAT test which is working very nicely, and it's very cost-effective also, very cheap and very effective also. So these are the screening test modalities, the rapid CAT test which the government of India has adopted, being tested across the country in a very massive way, and government has set a target that we should do for these things. So these are the screening tests for that. Now, the screening tests are qualitative tests and are unable to detect and capture hemoglobin E, beta thalassemia, and compound heterozygous samples such as sickle beta thalassemia, thereby giving a false negative result. Means you cannot capture it. So that's the limitations of the screening test, which is designed only to capture hemoglobin S. Now, the confirmatory tools other than the genetic, first the HPLC was the oldest one. HPLC, it requires a highly skilled laboratory technicians and its monitoring. I won't go to the details of the principles of the HPLC, etc. But it's a well equipment, etc. You have to standardize its process with your training, etc. It can be set in the laboratory, in the hospital setup. Practicing, utilizing it at field level, PSC level, or community level, it's a big challenge. The principle of HPLC is that it's a cation exchange. You know, it has a equipment. I'll go to the next slide. It has 3 components. One is a buffer, means your solution. You have a pump which pushes your buffer through this injection valve, controls the passage of your buffer. You have a central cartridge which is a negative charge. Then, as you know, the hemoglobins are also negative charge, or the positive charge is the net positive charge. We say when travels with this negative charge cartridge, so every protein or every hemoglobin have a different net positive charges over the surface. Accordingly, they get precipitate at the differential of the time. That's how it gets precipitated. So suppose this is the hemoglobin. Suppose this is the absorb. This is the buffer goes it here. Now this abnormal. So this hemoglobin is precipitated here. Suppose this, and so in the graph this will be appeared as a chromatograph like this graph. Suppose there is a second hemoglobin is there, it will precipitate here, and the buffer will, and in the chromatograph in the film it will appear like that. Suppose you have a third hemoglobin variant, it will be precipitated here, and it will appear like this. And now the last one will be here, it will be precipitated here, and it will appear it. You know, there is a software system inside the component, inside the equipment, depending on this area of precipitation, it will exactly give what is the percentage. So one does not have to calculate anything. It's a software driven things. Automatically by seeing the area of the precipitation, it will give them a percentage. That's why. The second one is the capillary zone electrophoresis. It is again, it's a made in France. It has a capillaries instead of a cartridge. Principle is the same. Instead of a zone, that is how they have a 13 zones. So how this is the same different type of the hemoglobin. You have a zone 1 to zone 15. 15 different hemoglobin can be precipitated in the different zones. So this is the how your hemoglobin A is concerned. This is the hemoglobin F zone. This is the hemoglobin S. This is the hemoglobin A2. And this is the hemoglobin C also. In this way, the same principle is also in capillary zone electrophoresis. You can get so many variant also. Now let's go to the how you are going to interpret also. Interpretation is the principle same applies for the HPLC, capillary zone, and Ghazal also. Interpretation is you have to interpret by from the relative percentage of individual hemoglobin variants. I will give certain examples also. If it is a heterozygous or beta thalassemia trait, the normal hemoglobin, suppose you have a beta thalassemia trait, the hemoglobin A2 will be 3.5, it's not 3.2. In India, it will be 3.5, which is more than the normal upper limit of A2 is 3.5. If it is more than 3.5, hemoglobin F will be 0.5 to 6%, and predominantly there will be other hemoglobin A. Probably it's a case of beta thalassemia trait. Similarly, if you have a homozygous, so the predominant hemoglobin will be hemoglobin F. It varies from 70 to 90%. on your hemoglobin A2 or A level has no relevance in diagnosis of the beta thalassemia major. If your hemoglobin A is more than 70 to 90%, probably you are dealing with a beta thalassemia homozygous. I think there are many patients, if there is the beta thalassemia intermediate, you can have a hemoglobin F which will be variable, can vary from 5 to 100%. You have to decide which is intermediate because of the clinical severity. Now come to your sickle cell heterozygous. If you say sickle cell homozygous, if the hemoglobin S is the predominant fraction, which can varies from 55 to 90%, A2 is less than 3.5, more than 3.5, F can vary in between 10 to 20%. It's a classic case of the sickle cell homozygous. So it is the relative percentage of the different hemoglobin variants. If you compare with your normal hemoglobin, that will give rise to your interpretation clue whether it's a normal trait or any measure. Similarly, hemoglobin S, if it is a heterozygous, here S will vary from 35 to 40%, and A2 will be more than 3.5, and the majority hemoglobin will be A. It will be say more than 50%. So that's the principle of the sickle cell heterozygous. So in heterozygous, the abnormal hemoglobin either S or E will be less than 30%, and the A will be more than 50%. If it is homozygous, the major hemoglobin will be more than 50%, either S or E. Similarly, if it is the hemoglobin E heterozygous, if it is in between 25 to 35%, rest is A. And if it is E is more than 95% and very rudimental hemoglobin A for A, probably it is the case of hemoglobin E homozygous. So the principles remain same, and you have to take the variable percentage of the different hemoglobin, comparing with the normal hemoglobin with other hemoglobin F, hemoglobin A2 or E or S. You can tell exactly whether it is a normal case or it's a minor or it's a major. That's the principle. Now normal, these are the few examples of the say HPLC. This is the normal, means that it automatically comes in the chromatograph. You don't have to look at that. Hemoglobin F is 0.9, A2 is 2.5, and predominant A is 85%, is a normal. It's a beta thalassemia trait. Here is A2 is more than 5.2, F is 1.7, and A is 85%. It's a classic case, the beta thalassemia trait. Similarly, here the F is 41.8% and A2 is 1.5, it is a homozygous type. So this is another case. If A2 is 4.3, it is a beta thalassemia, it is a sickle. Here S is 37.4, A is 55.9, it is a sickle cell trait. Similarly, here the S is 75%, 3%, and F is 13%, it is a sickle cell homozygous. Here I will tell you one point of caution. You cannot have a means to differentiate from either sickle cell homozygous or sickle beta thalassemia from the HPLC, because here the Arab Indian haplotype, the hemoglobin F are relatively high. It can vary from even 5 to 30% also. Similarly, the sickle beta thal also, you have a high level of the hemoglobin F along with hemoglobin S also. So unless and until you compare with other parameters, just by seeing the HPLC report, you won't be able to differentiate between whether it's a sickle cell homozygous or sickle beta thalassemia in every case. Similarly, hemoglobin ST Punjab, the same way. Here you have a SUG 37% and hemoglobin D is 41.5%. Sometimes we do see also hemoglobin D Punjab along with S also. In this way, it's a very simple format to differentiate and diagnose once you get the chromatograph report. I think that is at E trait. Same thing, this is a E trait. The hemoglobin E trait, that is a E homozygous, where the A2 means it's hemoglobin E, which is roughly 69.5%, and it's a beta thalassemia. It's a E beta thalassemia, means E is about 54.5% and F is 14.5%. Same principle also. All cases you may not able to differentiate between E homozygous and E beta thalassemia. You have to compare with the other parameter also. Now the last confirmatory I come you, that's a new version which has come it a microchip electrophoresis made by Gazal hemoglobin variant. It's an in vitro diagnostic device that uses miniaturized version of the electrophoresis with a high-end your software systems, which will automatically, same principle, here the principle is same as electrophoresis, but you have a very high-end software system which will automatically capture the percentage of the different hemoglobin which gets eluted in the electrophoretic platform and automatically gives the percentage, the way the HPLC and capillary zone electrophoresis gives it also. This is an example. Not suppose you have put the sample here. Now the sample goes it. Now once the brand is created, automatically we have a graph, and automatically it comes as one percentage also. It is a hemoglobin. S is 40%, A is 58%. So it's a sickle cell trait also. That is how the automatically it comes the way HPLC or capsule electrophoresis gives also. The results are like that. You have a printed is there. You have a GPS system. You have a software system. Even it can be uploaded directly in the portal also. That's the added unique advantage over HPLC and capillary zone electrophoresis. And the same thing results can be depicted here. Print, you can go to a print, or you can upload in the portal system also. It's a very user friendly, very small, portable, don't require any electricity. Even without it, you can charge it, or with battery also you can operate. So you don't require any sophisticated laboratory systems. With a minimum training, you can practice in any village, any community level, even in the hospital level where the turnover is limited. So key solution is that Ghazal, I will just tell you, it's a very busy side. I won't go, I will only highlight the important point. It gives rise to 19 hemoglobin variant can be detected. So it has an automated interpretations with quantification I show you. It's a confirmatory single test results. Once you do it by Ghazal, no need to go for the HPLC or capillary zone electrophoresis. It's an inbuilt and online data storage. That I told you, inbuilt and online data storage. Easy to use, portable, battery operated, and capacity building is easy. And the most added advantage is that it can be uploaded in the portal. That's the mandate of the government of India, where the HPLC capillary zone, you have to manually put it into the portal system also. Now quantification of Ghazal, I think I will skip that. We've already done it. The same principle, the way you interpret, same way you have to interpret whether the beta thalassemia trait, intermediate, major, the same by comparing the different hemoglobin percentage. We have in Odisha, probably we validated, we compare the, so this Ghazal report with our HPLC report in the NHM office, we put 40 very highly dynamic samples having a range of the normal, you have abnormal hemoglobins like hemoglobin S, hemoglobin E, both trait and major, even sickle, beta thal. Even some of the samples were blood transport samples also. We deliberately put it also because equipment may be sensitive in the low level or high level. It may not be the intermediate level. So if you look at the variable of the different hemoglobins, it was in starting from low to intermediate to high also. We tested it. And what is the surprising also, we took 40 samples, sickle cell trait 7, sickle cell disease 14, beta thalassemia trait 6, beta thalassemia major or intermediate 4, normal well 4, unknown hemoglobin pattern 2 also, and sample, there was a clotting in 3 patients. So the total was 47. So what you find, it was almost, when you compare it, every data is there. If you look at the diagnosis, every diagnosis, in each case, the diagnosis is exactly matching with what we reported by the HPLC, which was a double blind, and it was not known to the Ghazal guy who was doing in the NHM office. So we concluded and we give official report is 100% matching with the HPLC report, and we have submitted for the publication also. Hopefully it will be accepted. It will be published in our PubMed journal also. So this is how it has been tested, validated, and that. So now we have the comparison between all the 3 confirmatory tests. You have a Ghazal, capillary zone, electrophoresis severe, and HPLC biorad. I won't go to all the parameters. The technology is known. Principle I have already told you. Look at easy to use, is probably the easiest. Ghazal is the easiest to use, can be used at any level of our country, be it village, be it your PSC, CSC, or community, whatever, maybe even in hospital also. I think government of Odisha has started that also. The second is a cloud and data storage. That's yes, as I already highlighted. Third is automated digital documentation that is there in everything. If you look at the GPS system also, that is there only in Ghazal. It's not available in HPLC or even capillary zone electrophoresis. So the quality wise, sensitive wise, specific wise, though it matches, so all the three are equal effective or equal good equipment, but because of this portable, easy to use, and this data storage system done, you have technology to directly upload in the portal, and easy to use, can be used at community level. That scores, that's the probably preferred equipment to be used at community level so far in the in our sickle cell elimination program. So to conclude, ladies and gentlemen, the pathophysiology of the sickle cell disease is because of the hemolysis and vasculosis crisis and infections for the regions which I have already explained. The diagnosis can have you have a screening and then you have a confirmatory test, I told you. The screening can be done by the EG rapidly and favorable by your rapid CAT test. The logistics has to be compared, and the screening test only captures the hemoglobin S. It escapes other hemoglobins, they escapes by the screening test. So for the confirmatory test is there, we have HPLC, capillary zone, and microchips electrophoresis by Ghazal. And second, so for the microchip electrophoresis, it has advantage because it can be used at the community level, can be used at the hospital level. It has a data and GPS storage system which can be used, this technology can be used in our elimination program. And of course, in genetic study, in few cases, in a borderline cases where you cannot determine the exact phenotyping or exact genotype, there may be required so far in few cases for the confirmation of the patients or which category belongs by the genetic study. So thank you very much for your attention, ladies and gentlemen. Any comment or any questions or anything? Yes, yes, ma'am, please. Look, so far the cost is concerned, again the cost varies on how the cost can be reduced depending on your number of tests available. As for example, so far the Odisha government is using this HPLC. I think, Dr. Saab, what is the cost we have reduced? Probably it is now 70 rupees for HPLC test. Whatever the logistic, because once you are using more and more, suppose few lakhs you are using, it can be reduced, can be even 50 to 170 rupees. And so far the same thing for the capillary zone electrophoresis also, equality is also. So far by Ghazal is concerned, what will be the cost in the mass scale of the Ghazal? Because Ghazal equipment is only 2 lakhs rupees, when it can 2 lakhs rupees, it can be there. Maintenance and etc. is very, very less. But for purpose, they have a huge cartridge, and I am sure once you use more and more lakhs, so for a community level, the cost will come down. The more you require, the cost will come down. Just say for rapid CAT test, when you procured at the first year, in the initial phase, it was Government of India give a recommendation 200, it will become 100. Now Odisha has procured in 42 rupees. So 42 or 44 rupees. All depends on how the time passes, number of the competitions, and how much you want. Look, gel electrophoresis, alkaline electrophoresis is only confined to these pure laboratories where if the approach controversial, etc., you can use it. But now its uses is now has gone down because maintenance, interpretations, taking a trained technicians is very, very difficult. So nobody really using for that. Only in few selected hematology laboratory we use for only study or for research purposes. Because utility at community level has never been valid or never been sustainable. So yes, sir.
Sir, in our books, we have been studying that HPLC has been a gold standard test for diagnosis of all the hemoglobinopathies. Is it still a gold standard or it has been changed?
Now look, HPLC is a gold standard, a capillary zone is a gold standard, and the micro electrophoresis is a gold standard. The books which I have said to Dr. Gautam and Mr. Gautam, you can check it also. Yes, yes, it's there also. Because HPLC is a very oldest one, it is being commonly present, and everybody tells HPLC, and capillary zone is much more superior. Capillary zone electrophoresis is much more superior HPLC. I have to persistently fight your NHRC meeting so many times. Why you are telling HPLC? You have a equally or more effective. Capillary zone, you have a zone 15, and you change the mode, you can go for the even protein electrophoresis. You can go for the immunoelectrophoresis also. It has a lot of advantage. Similarly in Ghazal, Same thing, there was a confusion by your, again, NHSC meeting that once you do when a ghazal is not confirmatory. I again raised my point in that meeting since I am a member also. Once you have done by ghazal, it is confirmatory. There is no need to repeat by HPLC or by capillary zone. So it is a wastage of time and energy and logistics. So all three are confirmatory. They are based on these principles. HPLC is a gold standard because it has been told and many gold standard has been added. So we lot of difficulty. We introduce this capillary zone and ghazal along with slash HPLC slash capillary slash ghazal as a microchip. Because people who are there in the Delhi, they are not so much of exposed. They are not so much oriented what is coming up in the recently. Even those most of the members who are there, they are not so much acquainted with so far the diagnostic hematology is concerned. So that is why these things. You will be, because I will be leaving when Dr. Sahu will come. Odisha was the first state in the entire country who gave the DBS technology, the dry blood spot technology. You know how much of hangama cry was there from Delhi. Why you are using, what was the reason, etc. So now look, it is now approved. I remember so far the hemoglobin pathita is concerned. Eastern India rules. In the department in Cuttack, probably Asia's largest HPLC lab. In one room, we have a 70 HPLCs functioning every day. 10,000 samples are screened. In my department, we have 6 HPLC and 2 capillary zone electrophoresis. So hemoglobin pathies are screened in a massive way so far Eastern India is concerned. I think now the previous technology, and I am sure ghazal is well accepted, is a very handy, can be used as a confirmatory test across the country at community level. Okay, Rajesh, is all, or any more question, any comment? Okay, thank you very much. Thank you for your attention.
Thank you very much, sir. Your vehicle is ready. I have sent you vehicle details. Sir has to rush for his flight. So I invite Dr. Garima Nirmal to talk on specificity of Indian sickle cell disease. She has been working here now in Apollo, and she has been coming up with lot of publications this year and last year in sickle cell.
A warm good afternoon to one and all. I would like to thank Dr. Pandharkar sir and Sarvodaya to give me this platform to share my views on specificity of Indian sickle cell disease. So sickle cell disease is the most prevalent genetic condition worldwide. The global burden of sickle cell disease is increasing. The annual number of sickle cell disease newborn were expected to increase from 300,000 to 400,000 in around between 2010 and 2050. So the sub-Saharan Africa is the worst affected area, followed by India. And in India, it was estimated that children with sickle cell will be around 42,000 by 2010. So this slide shows the global burden of sickle cell disease. The darker the shade of red, the more the prevalence of sickle cell disease. So the worst affected areas are African areas, India, and America and Mexico because of the immigrant population of the Africa in these areas. When we talk about the burden of sickle cell disease in India, it is mainly affecting the tribal population, which comprise 8% of Indian population, and scheduled caste, which comprise around 10% of the population. So it's estimated that in 1 in 86 births among scheduled tribe have sickle cell disease. So this is contributed because probably of greater selection pressure on these group from malaria. higher rate of endogamy in these tribal population, and competitive evolutionary exclusion of sickle beta by beta thal. And India has incredible diversity in socioeconomic and ethnicity. That's why there's a regional difference in the severity of disease throughout the India. So in a study by ICMR, around 20% of patients from sickle cell disease, they died by age of 2 years. And in tribal community of Maharashtra, there's study in a tribal community of Gujarat, around 30% of patients with sickle cell disease in tribal population, they die before they reach adulthood. And it comprises various morbidity because of increased incidence of cerebrovascular disease, acute chest syndrome, renal failure, increased dialysis, and premature death in these patients. So this map shows the prevalence of beta sickle in the different parts of India. The central part of India is affected the most, including Maharashtra, Madhya Pradesh, parts of Gujarat, Tamil Nadu, Kerala, and parts of Jammu Kashmir. So when we see about the tribal population, in tribal population, central part of India is worstly affected, which includes again Madhya Pradesh, Maharashtra, Gujarat, and in the non-tribal population, Jammu Kashmir is affected the most, followed by Tamil Nadu and Madhya Pradesh. So historically, the phenotype of sickle cell disease in India was considered to be mild as compared to African counterpart, probably because of higher percentage of fetal hemoglobin, co-inheritance of alpha thalassemia, higher total hemoglobin, lower retic count, and presence of splenomegaly in these cohort of patients. So in the studies, the prevalence of alpha thalassemia was around 16% in central India, 50% in Odisha, and 86% in Valsad. So this coexistence of alpha thalassemia with sickle, it reduces the severity and it reduces the organ damage, but paradoxically, it increases the pain episodes in these patients. So this is the data from 114 patients where baseline fetal from Odisha, where baseline fetal hemoglobin is as good as 20%. So if we talk about the different haplotypes, so there are predominant 4 haplotypes from Africa, which is Senegal, Benin, Cameroon, and Bantu. And in the various studies, the mean fetal hemoglobin is in 1 digit. In contrast, in the haplotype of Arab Indian, so this is a population of Indians or the Indians who have migrated to Arab. So here the mean fetal hemoglobin was 20%. And we know higher the percentage of fetal hemoglobin, lesser the symptoms are. So that's why our patients have higher mean fetal hemoglobin. And when we talk about the differences between Indian and African sicklers, so incidence of invasive pneumococcal disease is higher in African population as compared to the Indian disease. And spleen is central to the pathophysiology of sickle cell disease. So the incidence of acute splenic sequestration is more in African population as contrast to Indian population. And chronic leg ulcer, which we say that if your leg ulcer persisted for more than 6 months, and incidence of priapism is as high as 30% in African population, but in Indian literature, it is found to be less than 1%. As we have already seen that fetal hemoglobin is more in Indian population because of Arab Indian haplotype. The splenomegaly has a later appearance in Indian population. And for African cohort, we need higher dose of hydroxyurea to alleviate the symptoms. But in Indian cohort, studies have shown that even using fixed dose of lower dose of hydroxyurea is effective in alleviating the symptoms. And this is a paper from Sargent et al., which has shown that comparison between Jamaican and Indian sicklers, and they have found that the Indian sicklers have higher fetal hemoglobin, lower retic, and higher fetal hemoglobin and higher total hemoglobin. So this National Sickle Cell Elimination Program was launched by Honorable Prime Minister in 2023, which aims to eliminate sickle cell anemia by 2047. And they have distributed sickle cell genetic cards to the beneficiary. And their aim is to target around 7 crore of people under 40 years in the next 3 years. So we talk about the screening pattern of the world. So only some countries follow national screening approach, which is by in the northern part of America, Brazil, and Saudi Arabia. In India and Canada, they mainly follow regional screening pattern. So that means they subdivide the endemic states into different blocks with the prevalence. So states with higher prevalence they adopt for universal screening, but state blocks with lower prevalence they advocate target screening approach. So in general, universal screening and confirmatory testing are offered to people under 40 years in area of higher prevalence, and they have denoted 17 states with higher prevalence. And screening could be done in two methods. The one is you just go directly to the point of care test, which could be your electrophoresis, HPLC, or your Gazelle, or you adopt the two-state approach. That means you do the initial screening test like solubility test, and if it comes positive, you go for the confirmatory test. And government has distributed these sickle cell cards. So blue is for boys, pink is for girls. So these are marriage cards. So when you want to marry somebody, you match your cards, and it will show whether your next progeny, what is the percentage of normal, of sicklers, or of trait. So with that, you can choose your life partner. So if we talk broadly about the management of sickle cell disease, so it includes prophylactic management, which requires folic acid and oral penicillin B. In preventive management, we educate them to have a proper nutrition, to methods to avoid crisis, health maintenance. And the treatment options includes drugs like hydroxyurea and other newer drugs, crizanlizumab, voxelotor. Then hematopoietic stem cell transplant and gene therapy are the only two curative options available in the patient with sickle cell disease. So hydroxyurea, through a multiple mechanism of action, it will increase the fetal hemoglobin, and it's a single agent, inexpensive, orally administered drug, and it increases the fetal hemoglobin, total hemoglobin, and it can be prescribed in children and adults in more than 9 months of age. So this was a study published in NEJM, where they have seen that so they prescribed that hydroxyurea should be increased with their tolerability. So you start with 10 to 15 milligram per kg, and then every 2 months you increase it with a margin of 5 milligram per kg per day. And with your maximum tolerated dose, you achieve the better symptoms. This was published in NEJM. So here they have seen that if you choose a fixed dose regimen versus a dose escalation regimen, so in dose escalated regimen, you have improvement in hemoglobin, MCV, and fetal hemoglobin, and your retic count, neutrophil count, and platelet count will be reduced. That's what we want when we use hydroxyurea. But it is not always possible to adopt this escalating approach. So you need a proper healthcare worker to do that. So instead, in India, there are plenty of studies which have found that using low dose fixed hydroxyurea is effective. So you use either 10 to 15 milligram per kg of hydroxyurea, because in India we have two formulations available, either 200 milligram or 500 milligram, but there are no pediatric formulation available. So you choose your nearest formulation, nearest tablet, and you give it. And with this, they were able to attain good symptom-free period. And this was even analyzed in this systematic review, where low dose 10 milligram per kg per day was quite efficient to reduce the veno-occlusive crisis, reduce the hospitalization. And like hydroxyurea, adherence is very important. So you prescribe, but sometimes patients don't take. So there are this study in American Journal of Hematology which says that if your adherence is good, then it will lead to decreased complications, decreased ER visit, and decreased hospitalization. But what are the obstacles for prescribing the hydroxyurea? So first is unavailability of this drug in the infrastructure, poor compliance of the patient, the hesitancy of the physician to prescribe this drug, because they think that it is a carcinogenic drug. They will think that the marrow will get suppressed. So there are a lot of notions about this drug, and the lack of experience of these attending physicians with hydroxyurea. So this is analysis we have done in 416 healthcare workers, which was published in Blood. So we have given one questionnaire to these 416 healthcare workers, and out of them, 2/3 health workers were involved in the care of these sickle patients, and only 15% have received some sickle cell training. So we have used a validated questionnaire, that is DF-CoHNO questionnaire, and among them, around 38% have worked for more than 10 years. But when we have assessed the knowledge, only 12.5% healthcare worker had adequate knowledge. Rest 87.5% have inadequate knowledge. And when we talk about the sickle prevalent zone, only 14.7% healthcare worker had adequate knowledge, and non-prevalent zone only 2.6% had adequate knowledge. So these healthcare workers, they are the pillars to elimination of the sickle cell program. If they don't know, then it will be difficult to achieve this goal. So this is a roadmap by India, National Cell Elimination Program. So they say that they will prescribe this prevalence-based screening followed by confirmatory testing for epidemiology. And then they use this telecommunication and apps for counseling for awareness in the population. And then the next focus will be on the therapeutics. So to create these dedicated sickle care centers, to give training about hydroxyurea, to give counseling about nutrition and dietary aspect, and then to advocate for hematopoietic stem cell transplant, also the one who needs it because it is a curative treatment, and to start the indigenous trials for gene therapy. And sickle cell disease, Government of India, it has considered it as the disability under the Right of Person with Disability Act. So the patient with sickle cell disease, they're eligible for free education up to 18 years of age. They will get 4% reservation in the education and the government jobs. They will get 5% reservation in the higher education and other rights. So we should also educate them about their rights. So if I have to conclude my talk, I should say that India is the second worst affected country by sickle cell disease after sub-Saharan Africa. Arab Indian haplotype is prevalent in Indian sicklers, which is quite a milder phenotype. Compared with the African sickle cell disease, Indian sicklers are mild in severity, although severity of sickle cell disease differ in various states of India because of lot of factors like co-inheritance of alpha thalassemia, presence of fetal hemoglobin. Then low dose fixed hydroxyurea is effective in Indian sicklers. So we can start with this approach. And the knowledge of healthcare workers about sickle cell disease needs to be improved to achieve our goal of national sickle cell elimination. Thank you.
Thank you very much. Are there any questions? Yes, please.
Absolutely. Yeah, true. That's true. It's a quite safe drug. Thank you.
So there is one more question from the net. Are there any new drugs approved for sickle cell disease other than hydroxyurea available in India?
So the newer drugs are trizanlizumab, voxelotor, which is approved for sicklers.
Available in India?
It is available in India.
Both?
I think so, both.
Thank you. Any other question?
Thank you.
Thank you very much. Our next presentation is again a very important presentation, and we would like to know the status in Chhattisgarh. So, you know, Dr. Patra is a director of Sickle Cell Institute, Chhattisgarh, one of the very old sickle institutes. He is a pioneer, and lot of basic work done by him, lot of publication by him. We are really honored to have Dr. Patra with us, who is at the same time Vice Chancellor of the Chhattisgarh Medical University. Dr. Patra, sir, welcome, and thank you very much for joining us.
Hello.
Yes, sir, we can hear you.
Okay. Thank you, sir. Sorry, I could not attend there. Actually, I'm in a very remote place. Also, I am sorry, I am not able to share my presentation also, but it is happy to connect with you and join you all. And thanks Dr. Pendharkar considering me. And actually, I am in the holiday. I am in the very remote place, and I will go tomorrow. And anyhow, so I will just say share my view.
Okay, sir. Thank you, sir.
Dr. Pendharkar has organized a beautiful meeting, and it is a good platform, but unfortunately, I am not able to join there. I am thankful to Dr. Pendharkar and congratulating all his team. Actually, we started working in sickle cell disease very early. When in India, very countable people are working on sickle cell disease. That is, I started and I inspired when I was an MBBS student. And Dr. B.C. Kar, who was the first medicine in Burla Medical College, he was my teacher, professor there. And we started associated with him. And that time, very people was working, that is Dr. Deepti Jain, Dr. Italia, Dr. Bhutish Patel, and the few people are working. And now it is a very good time for us as a sickle cell worker. There's so many people are working now in the sickle cell for the sickle cell cause. And it is a very happy moment for us that the government of India and different state government is also interested and showing, started so many project, and government of India also initiated this project. Sickle cell is almost a nucleus for the sickle cell gene prevalence. That's in Chhattisgarh and the whole state. The Chhattisgarh came to the existence 2000. And this area that like this adjacent to the Chhattisgarh, Odisha, then the Bidar, the part of the UP, that Jharkhand, Bihar, all have associated the sickle cell gene. The area to the Chhattisgarh, that is the things what we found in the during our working. The sickle cell gene is prevalent sickle cell gene prevalence in Chhattisgarh. And one thing is that I was trying, but it's because it is very link is very sorry. In 2017, we started one project, that's the school-going children. That project was funded by the government of Chhattisgarh. And there, we prefer to start the school-going children as it will be easy, and it will be economical also. That is why we started there, the school-going children. And yes, I was just attending the previous talk. Madam was telling about this, the solubility test and confirmatory. We started there that time the solubility test also, and the cellulose estate paper electrophoresis. Combining these two, we screened out almost 20 lakh sample, and we found 10% gene prevalence is there in our Chhattisgarh. And seeing this, our government of Chhattisgarh started, and that was the brainchild of our the Bharat Ratna APJ Kalam Sahib. He was our chief guest there in 2008 meeting in Raipur, as the international sickle cell meeting. So here, the concept that there should be a dedicated institute for sickle cell, that there should be a comprehensive approach, that screening, then diagnosis for the healthcare personnel. So this time we started this sickle cell institute in Chhattisgarh in yes, is it my presentation is seen, sir, please?
Yes, sir.
Yes, sir. Thank you, thank you. Yeah, it is moving.
No, sir. Just put presentation on a slideshow mode. Then.
Just
Sir,
a minute, just a minute, just.
So first do enable editing.
Enable editing, yeah.
Yeah. Now just put it on the slideshow mode.
Is it now okay? It's moving?
No, sir.
Sir, please click on the slideshow mode. It is on the bottom right side of your screen, where 80% is shown, a little left to that first button. No problem, sir. Let's start. Yeah. Okay, we can start without the full slideshow mode. Please, sir.
Okay, okay. So, I'm audible, sir.
You are audible.
I'm audible, sir.
You are audible.
So I'm continuing because the signal problem is there. Yeah. So there we started
Sir, I think you should put the video off. That will give a better.
Content director there, and the institute concept as yeah.
Sir, you can put the video off, then it will be better because the signal is poor.
Yeah, I have made the video off.
Slides also you can put off. You can put the slides off.
Actually, the signal problem is there.
Okay. Okay, go ahead, sir. Go ahead.
Okay. Sorry, this is the technical glitch. I told I am the main motive. The things is it should that the sickle cell patients was very as you all know, and with this prevalent 10% gene frequency is there, and another is the here OBC population is also there. So this is marginalized people. They are they don't come to the what they are selected almost. So now it is this Sickle Cell Institute. This was conceptualized in 2008, and we started in 2013 in the government of Chhattisgarh. So that was this comprehensive approach: the screening, training of the health professional, diagnosis of the disorders, counseling, marriage counseling, and further treatment. Because one thing I have experienced, these heterozygote peoples are they are exploited by the physician and the different system of medicine. They also treat this heterozygote. So actually, this is a Mendelian recessive disorder. So heterozygote usually don't need any treatment. So in this context, so this heterozygote has to be properly counseled for this treatment management, and and for the marriage council mainly. And homozygous, they have to regularly follow up, and they have to be taken care from birth to death. So this type of awareness campaigning we did, and it is our experience that they are in, when we are going to the field in 2017, they were snatching my key, but nowadays they are calling us, doctor, please come and do the screening in our area and do the counseling, marriage counsel, etc. This is the public awareness we got, and we are, as the madam was telling about the card, here I usually against the card, because color coding, they may create some stigma, but there was the same type of card was given here in Chhattisgarh, and now it is now uniform government is giving. But in my project, we are giving the very small card, and patients who are very happy with this card to carry, easy to carry, and they are heterozygous, homozygous, counseling material was also there. So there, then I was also started the training of the work, that the health professional, the policy maker, the local politician, the social leader. So they did lot of things for us for this genetic disorders condition. So I mean to say, this comprehensive approach helped a lot to improve the sickle cell patient in the Chhattisgarh, and we got the very good result. And now in Chhattisgarh sickle cell institute is there in Raipur. Now it is functioning in the Raipur Medical College. The independent building is construction is going on, and government is also very keen and working on it. So the other activity in the Chhattisgarh, that they are regularly with the support of the state government, and we are approaching to the patient, and that is the good help we are doing here. We are approaching to the patient because they are tribal population and very poor and very not very aware of this. So when we are approaching them, so they are feeling confidence that bhai hamare liye bhi koi hai, and there are something, this type of feeling they are getting, and we are getting the tremendous result. So that is the my view here in from the Chhattisgarh. I'll be happy, Dr. Pandarkar sir, please any interaction or any question. And sorry for that, for the technical, I could not I can what happened, the slide I cannot show. The GIS, there is a good work we did here in the public awareness, and the counseling material also we will give, and anything, sir, any questions, I'll be happy to answer, sir. Please, sir, over to you, sir.
Sir, thank you very much.
Hello.
Sir, thank you very much. And
sir, please, sir.
We wish you were
sir,
here.
Sir, thank you, sir. Sorry, I was not able to attend there. Yeah.
No
yes,
problem. Sir, thank you very much for the Chhattisgarh data. And we have got team of NHSRC here, so they've also listened to you. And probably we can come out with some minimal changes to the existing program, taking into your suggestions. Thank you very much once again.
Yes, sir. Thank you. Thank you, sir.
So
Thank
our next presentation is by the scenario in Odisha by Dr. Dinabandhu Sahu, who is in charge of the sickle cell program in Odisha on behalf of NHM. Dr. Sahu, please.
Good afternoon. Thank you, Dr. Penalkar, giving me the opportunity to present my state before. Greeting from state of Odisha from Lord Jagannath. As you know, Odisha is working on sickle cell anemia since 2010. Next. If you see the prevalence of sickle cell all over the India, the zone, high prevalence zone comes, Odisha comes in high prevalence zone, that is 21 to 40%. Odisha, Jharkhand, Madhya Pradesh, Chhattisgarh, Maharashtra and Gujarat. The incidence vary from 5 to 40%. And in Odisha, it is around 21 to 40%. And it is restricted to in few castes like Agharia and Patel family. And it is more because of endogamy and consanguineous marriage. Seeing the prevalence of sickle cell in Odisha, this Center of Excellence was established in the Western Odisha, which has more prevalence in the 2 phases. Total 12 districts were taken. These are the districts colored with yellow and pink, first phase and second phase. This is a day when it was instituted in Odisha, particularly in the Western Odisha. The Honorable Chief Minister of then Mr. Naveen Patnaik inaugurated. The prevalence status was like that. The sickle cell prevalence was 10 to 15%, and the thalassemia is 6 to 10%. The sickle cell is more prevalent in the Western Odisha, and the thalassemia is more prevalent in the coastal belt. There are around 24,000 lakhs registered persons, 20,000 patients now registered in sickle cell, and thalassemia patients are 3,546, and these are the hemophilia patients. So this is continue up to 10 years. Then we are working only with sickle cell anemia. We have neglected thalassemia. Then the CMC people approach the state government to work both on sickle cell anemia and thalassemia because of the prevalence. And this was the MOU signed with CMC Vellore. That was in 2017. It was funded by DBT. Priority was given the antenatal pregnant women. Then the ADPHO was declared as the nodal officers. We could complete only in 15 districts. We could not spread to the 30 districts because of the pandemic COVID, and 2.10 lakhs of population we could screen. All the screening was done through the HPLC, and we have started the CVS testing method in the 3 medical colleges, and we have trained about the 11 persons, including the AIMS Bhubaneswar. The launching of sickle cell anemia elimination program was on 1st July 2023, and we have carried out in the 20 districts of our state. The target was given around 22 lakhs, and the target group was 0 to 25 years in first 3 years. This screening platform was Anganwadi centers and schools through this RBS team using the mobile health unit, and with the ANM in the VHN session, and opportunity screening the patient those are visiting the institutions. This screening method were by point of care and the Gazelle in the institutional points, and Odisha is the first state where we introduced the DBS technology, but Dr. Jena was talking. And by that, we have achieved 18 lakhs, around 19 lakhs of screening by end of this financial year. So these are the scenario where my team is working over there and they are doing the screening work. These are the genetic card what Madam Garima was showing. So that we have already incorporated in our program, and we have already issued around 4,68,000 cards we have distributed in the 20 districts. These are the for female. We have already done POC by using POC kit. We have screened 12.5 lakhs population. Tender for another 20 lakhs has recently completed, and we have selected 2 agencies. Screening through Gazelle machine is now being carried out in 20 selected districts. DBS technology is now used in 7 districts. And we have to screen around 50 lakhs of population by this financial year 2024 and 25. And we have already issued this much of genetic cards. The treatment protocol has been developed in collaboration with the medical college and Dr. Pendarkar, who has visited during the development. And IC material has developed during this CMC failure, and today Government of India has circulated some of the IC material. The district public health medical officer has been declared as the nodal officer to carry out the program in that districts, and assistant manager NCD who is looking after most of this cancer care, he is declared as the nodal officer, and there is a program assistant manager in the all districts of that 13 predominated sickle cell disease. The real time data is captured in NSAME portal. The government of India has developed this portal. Hydroxyurea, folic acid, other chelating agent has been included in our EDL, and it is available in all the district headquarter hospital. As per the government norm, the community health officers has been trained, and the modules has already been developed in collaboration with the professors from our old medical colleges, and including Professor Dr. Pendarkar. And wherever they are facing any problem, they are consulting with the specialists through teleconsultation. And chorionic villus sampling has been developed and started doing. Until now, we have done more than 160 CVS sampling. And BMT, though we have not started, we have applied to declare our SC Medical College as a BMT center. These are the few of the IC material developed during the CMC period, along with the popular song of Sambalpuri Gana Rangavati, that being carried out by that the original singer to our the Western Odisha people. And you see the interest of our the then Chief Minister, who has given his photography in each IC material, how my people will be more aware about the sickle cell. That's why his photography is all the poster, all the banner. The government has also enthusiastic so that the more people will get the benefit. We are giving 500 rupees every month for transportation, consultation. Whether they are coming or not coming, if their name is enrolled, it is directly going to their account. We have added the chelating agent, helicofilter, and free blood to all the patients. This is the number of bloods we have given last financial year. This is the new drug we have included our EDL. Thank you. This is the work we have done for our state.
Thank you very much, Dr. Sahu. He looks after all the programs, so I'm sure you have got the glimpses of what is happening in Odisha. Odisha is one of the, I feel in healthcare system, it is one of the best, as far as system is concerned, organized place. So as you have seen his discussion, there are already state nodal officers defined, state NCD of district nodal officer defined, district person in charge of sickle is defined. They are already defined. Hydroxyurea is available in the district, but we are trying to now bring it down to the CHO level. CHOs have not been trained. We are starting with the training of CHO now. From initially we are doing 2 districts, and the 2 medical officers from both the districts and the sickle in charge from these districts are present in this meeting. So we have gone to that level, and I'm sure if we go to Sambalpur, Burla or Western Odisha, the usage of hydroxyurea, please mind my words, is 100%. And it's not today. It's for years. So this is one area in India which is using hydroxyurea and everybody is on hydroxyurea. There may be a reason patient not taking, but patients have been prescribed, they have been enrolled. So thank you very much, and great, really great thank you to Government of Odisha for really bringing out this program in such a good way. And I really want other states to look into the Odisha, how they could get 100% delivery of hydroxyurea in this place. Every patient carries a diary which has an HPLC report printed on it and a prescription of hydroxyurea. So this is what the state has already achieved, and in practice for last many years, I'm sure other states will also learn from it. Sir, thank you very much.
Thank you, sir, for your kind help and kind cooperation. Because of you, we are able to develop so many guidelines, and we are started the creating the nodal person who is looking after this daycare chemotherapy, and he will be the person for treatment and keeping the data. Thank you for once again.
Thank you very much, sir. So we're trying to develop a district sickle care model, as I said, and Odisha would be one of our first examples. The next data we would like to get from Dr. Anil Khatri on Gujarat state.
Thank you, Dr. Pendarkar, for inviting us today, and it's really a pleasure to be part of the deliberations. And it was really gladdening to see how fast Odisha has started and moved ahead. Well, my job is to talk about the Gujarat scenario, a brief about the epidemiology. Total population of the state is around 7.27 crores. Tribal population is approximately 1 crores. Sickle cell traits are 10 lakhs. Sickle cell patients are almost 70,000. A population survey done by Red Cross Society of 1.68 lakh tribals in 22 districts showed a trait level of 11.37%. Well, Gujarat started charting programs way back from 2006. In 2006, a comprehensive sickle cell anemia program was started in 5 districts of Gujarat on a PPP module. Why? Because things were not so channelized as far as government was concerned. So private NGOs who were committed to the cause came into the picture, and together with the development, a public-private partnership basis, a model program started in 2006. After 2 years, seeing the success, it was extended to 7 other districts, so it became 12. In 2011, the government formed a Gujarat Sickle Cell Anemia Control Society to oversee all the operations related to thalassemia care and screening, prevention, everything. So again, the society took up the work in an organized manner, and in 2012, screening was outsourced to qualified, competent and dedicated competitive agencies. Here I should say that each word is important, right? the agency doing the testing should be qualified, competent, dedicated, and also competitive as far as price is concerned. In 2015, we initiated the prenatal diagnosis program. In 2017, pneumococcal vaccine was started for all sicklers. Well, we developed a vision document at that stage. That document envisaged what to be done at what level. At primary level, primary care to be availed at PHC, CSC level, pain monitoring by charts and treatment with painkillers, folic acid, hydroxyurea, vaccination, and basic lab investigations like CBC for detection of anemia and for monitoring the side effects of hydroxyurea. Annual monitoring, I'll come to it later also, we'll show the data. Secondary care to be availed at district hospitals. Treatment of severe pain crisis, because it may not always be possible at the PHC, CSC level. So it has to be at the district hospital level where you get a dedicated team for it. Blood transfusion services also not available at PHC, CSC. So again, a district hospital is to take care of it. Transcutaneous Doppler to determine possibility of stroke. Monitoring for end organ damage, and HPLC to see effect of hydroxyurea. It's not been used much, but when we are using hydroxyurea as the main weapon to fight this disease, I think it makes sense to see the HPF levels to really see whether the hydroxyurea is giving an impact, it's effective, or how to escalate the dose or go for higher drugs, Tertiary care should be available at medical college or referral centers where there is facility for exchange transfusion. Exchange transfusion is most important in preventing immediate death for critical patients, because at that time only blood transfusion is not going to work. You need to have an exchange transfusion. ICU for stroke and severe crisis, joint replacement for those who have end organ damage, and high risk obstetric care for pregnant patients. Such a huge pool of patients. Obviously, so many of them will have pregnancy every year. So the obstetrician and the entire pediatric team has to be sensitized, and a medical college level, all these patients have to be referred to a medical college for obstetric care. Advanced care like provision of newer drugs and bone marrow transplant for those who extremely need it. So brief about the sickle cell disease care. Counselors, I spoke earlier also in the morning, have been trained to make them aware the patient about the necessity to visit the doctor, right? As we know, patient, if we tell them we are having sickle cell disease and the patient doesn't have a problem at that time, the patient is going to ignore it. So as now patient groups are getting more and more, vehemently coming out, it's very important that patients should be educated. What will be the outcome of the disease? What are the things to look for? How the pain has to be monitored, how pain charts have to be maintained, and how to identify the developing crisis and to visit the health center in time. At the same time, medical officers, healthcare workers, paramedics have been repeatedly trained. Now we have a very good system of 108 transport system, right? If a patient gives a call to 108, but 108 person doesn't know what sickle cell disease is and what is the importance of hydration in the times of crisis, and if it is going to take a lot of time to transport the patient, very critical golden hour is lost. So we need to train the paramedics also, that as soon as the patient of sickle cell disease has reported for crisis and needs to be transported, at least they could start with hydration in the van itself. So again, a challenge with the government health officers is, we see at many PHCs, I think there are in different states vacancies to the extent of 20 to 40% vacant posts of medical officers. So if there is not a doctor at the PHC to attend you, what you are going to do? And amongst the doctors available also, there is a high turnover rate. Many doctors who are bonded with the government, they will do the job for a year or 2 years and then leave the PHC. So it has to be a constant process, Training the medical officers is not a one-time thing. It has to be done constantly. Use of availability of hydroxyurea has largely improved. Just like Orissa, I think every center in Gujarat has hydroxyurea available for all the patients since so many years. Pneumococcal vaccine has almost universally been given to all sickle cell patients, and also all other vaccines to the children. we have been fortunate to have good blood banks with good enough stock. Gujarat is the capital of blood donation in the country. Not only the metro cities, but in the districts also. We have got excellent stock, good stock of blood, and the blood banks which are, I mean, it's in the genetics, in the genes of the Gujaratis to donate. So I think blood banks have less challenges than in other parts of the country. At the government level, there is a proper registry of patients in so many years. Monitoring program depends on self-monitoring by patients. At the PHC level, laboratory investigations will be important, and at the district hospital, monitoring of complications will be important. We started on a project, where normally a sickle cell patient would not go for any investigations because they are hardly visiting the health center unless they are in severe crisis. So we did a pilot project where we took up, we can see 17,000 patients, they were annual profile, biochemical profile. On a Mamta day, they would be called at the PHC. Their samples would be taken and the basic biochemical parameters like a CBC, LFT, RFT would be seen. To our surprise, we could see that 10% of the patients who were absolutely asymptomatic and just came for, because there was a monitoring program, were found to be having hemoglobin less than 5. So that really alarmed us. Also, it served as an indication because you create the buzz, when you do such days, at the centers. Patients, they talk amongst themselves and there is campaigning and people know what about sickle cell disease. They start visiting the center. So we got reasonable good success and we could do it. We do it for thalassemia also, for sickle cell also. But with the advent of COVID, this stopped. We have still not worked upon the data, which will come up probably in the next year. Now, sickle cell disease prevention program. We aim to do it early diagnosis through antenatal screening, adolescent screening, newborn screening and prenatal diagnosis, and prevention through marriage counseling, genetic counseling, and very important, building community awareness. This is the premarital screening data. This data is district wise. This is the data only of the Indian Red Cross Society. Some other NGOs have also done good work, so the total numbers would be much higher. But when we did in 33 districts and we screened 32.63 lakh, we could find 1.63 lakh thalassemia traits and almost 2 lakh sickle cell traits. So ours is a comprehensive program. We do an HPLC straight away. We don't go for a point of care test, and there are inherent advantages because we can detect both. See the huge numbers we have detected. At the same time, we do a CBC for all, so that prevalence of iron deficiency anemia is as high as 30 to 50% in different pockets. So while doing this, we can concurrently find out other anemias also and attempt to treat them also. Because when we aim for an anemia Mukta Bharat, I think our programs cannot be running, on parallel lines. Anemia Mukta Bharat one side, sickle cell anemia on another lane, third lane we go for a thalassemia Mukta Bharat. I think we won't be able to achieve. So our experience says that doing a comprehensive program for hemoglobinopathies makes more sense because you have got hold of the patient. It's very difficult in the rural areas to have the patient come to the health center only for screening. Very difficult. When we do in the best of the colleges, sorry to say, even in science colleges, attendance is less than 60%. In commerce college, attendance of students is 20%, 30%. So when you attempt to screen them at college level, the problem, the challenge is the availability of students and how many times can you go. So at the available opportunity, I think we should do an HPLC and try to find out everything. Similar applies to a pregnant lady, right? When she visits the center for antenatal care, I think you got the best opportunity to see whether she has anemia. Of course, it has to be seen. At the same time, find out sickle trait and thalassemia trait both at the same time. So antenatal screening and prenatal diagnosis has been going on in government hospitals, urban health centers and CHCs. All this has been supported by government of Gujarat and NHM also. So far, we have screened more than 8 lakh pregnant ladies and performed prenatal diagnosis for more than 2,300. And we could find out 555 thalassemia as well as sickle cell major fetuses, which were all aborted. So this is the real prevention. Premarital screening, we are not sure whether they still married and got a affected fetus, but this is a definitive prevention. So this is again the same data district wise of our prenatal diagnosis program of Indian Red Cross Society Gujarat State branch. Our action plan has been to identify and organize state trainers. There will be district level nodal health officer both for treatment and prevention. Again, those district nodal officers need to be trained and trained repeatedly, and all stakeholders, not only doctors, but nurses, lab technicians, counselors, and field workers. Counselors have been trained almost annually. When there was COVID also, online training was going on for these counselors, because to us, they are the very vital link between the healthcare provider and the patient. So creating SOPs, we formed our SOPs long back. We keep on revising them with experts. Our documentation process is very proper, and there is an expert group of the government which periodically reviews everything, because things going on, but you don't review what you are doing. Again, maybe you are not giving yourself a chance to improve. Areas of concern for us, debate about HPLC and POC. Again, a big issue, maybe a whole day is needed for that. We need to scale up our newborn screening. That is again a challenge, and we are looking forward to it. And timely and effective use of exchange transfusion to reduce the mortality of the patients. Thank you. I couldn't touch upon many things because time given to me was 10 minutes, but still I tried to bring the most of it. Any questions?
Sir, would you like to add little more to it? I'm here, Rajesh.
Yeah.
You said you wanted to add little
No,
more.
I could have brought more data and things, but I have not brought today. So.
Okay. सर मैंने कहीं सुना था कि गुजरात में जो टेस्ट है वो सिकल सेल का कहीं मैंडेटरी किया गया है, जो 10th के बाद 11th के एडमिशन में या कॉलेज के एडमिशन में, तो क्या ये सच है सर?
नहीं, वो बात चली थी, और एक्चुअली हमारे मंत्री जी ने एक बार कहा था कि हम सोच रहे हैं मैंडेटरी करने का, लेकिन मीडिया ने उसको थोड़ा अलग से ले लिया, और मीडिया ने ये चलाना शुरू कर दिया कि कंपलसरी कर दिया गया है। लेकिन मंत्री जी ने कहा था कि हम सोच रहे हैं। इसके बारे में 3 मीटिंग भी हुई थी, लेकिन डिबेट वहाँ चला था कि जब तक अपने पास पूरा इंफ्रास्ट्रक्चर ग्राउंड लेवल तक नहीं है, तब तक हम मैंडेटरी कैसे करें इसको। जैसे मान ले हम कि एंटीनेटल मदर के लिए हम मैंडेटरी कर देते हैं, लेकिन गांव में जहाँ पर आपके पास HPLC नहीं है, जहाँ आप उसका ट्रेट नहीं ढूंढ सकते हो, जहाँ पर उसका रजिस्ट्रेशन नहीं होता है, वहाँ सबसे पहले गवर्नमेंट को व्यवस्था खड़ी करनी पड़ेगी, उसके बाद ही आप उसका लॉ ला सकते हो। तो आई थिंक इट हैज़ टू गो अदर वे। पहले हमें ग्राउंड लेवल पे हर चीज़ ठीक ठाक कर देनी है, और उसके बाद ही मैंडेटरी के बारे में सोच सकते हैं। किसी ने पिटिशन भी किया था, कोर्ट में भी किया गया था, और हेल्थ अथॉरिटीज़ को तो कई बार पिटिशन गई है इस चीज़ के बारे में, लेकिन फिर जब हमारा एक्सपर्ट ग्रुप बैठता है तब हम इस निष्कर्ष पर ही आते हैं। कई लोग तो वेमेंटली प्री मैरिटल को भी अपोज करते हैं, लेकिन हम अभी उसको बंद नहीं करना चाहते हैं, क्योंकि हमारे पास हम इतने सालों से काम कर रहे हैं, तब हम यहाँ इस लेवल तक पहुँचे हैं। अब सोचिए अगर हमको इतनी दिक्कतें आ रही हैं, तो नई स्टेट जो इस काम पे लगेगी उसके लिए तो कितने चैलेंजेस हैं। तो वी वेलकम एनीबडी टू कम टू गुजरात, learn from our experience. We are ready to serve the country as a reference center from our experience, and I think together only we can make progress and make 2047 sickle cell elimination mission a reality, because it has to be on the ground, not on the paper. Thank you.
Yeah.
like you had mentioned in your slide about the debate between HPLC and POC.
Correct.
So, according to the GOI guidelines, before initiating the hydroxyurea treatment, HPLC has to be undertaken for all the patients. So, if you could just say, like, what exactly is the issue, like the debate?
No, I was talking about mass screening program,
Huh.
not about treatment part. HPLC.
Yeah, screening, okay.
Mass screening for prevention.
Mass screening for prevention that you prefer.
Because now we do a point of care test.
Yes, sir.
We don't do HPLC for everybody.
Okay.
Right?
Okay. Huh.
But we have been doing HPLC for everybody because we want to find thalassemia also, and we want to detect iron deficiency anemia also, and simultaneously address all the things.
Thank you, sir.
Thank you very much, sir.
Thank you.
May I invite Dr. Shivaji Kumar from Bihar to present the Bihar state scenario. So, he has been doing a lot of active work, traveling extensively all over the world, so many places. He has shared a compendium of documents to how to support patients. Dr. Shivaji.
Thank you. Thank you, Rajesh Sharma ji and Dr. Dinesh Pandurkar ji, who is inviting me for this program. Before that, this was my first physical meeting. Earlier, we have been participated in online meeting. So I thank before earlier my speaker, Dr. Tulika Seth, then the Dr. Ravindra Kumar Jena Shahab, Sri Gautam Donar ji, Dr. Anil Khatri ji, Mr. Lalit ji, Ms. Neha Verma, Dr. Ruchika Patel, Ms. Anil Tripathi, all before Anil Khatri ji. So I will be speaking more on the rights. What are the rights? Because my background is disability. I will tell I have done bachelor degree in mental retardation, master's, PhD. Then I have LLB. So all my expertise is disability sector. So I will be telling you what are the rights, RPWDX. I have been represented 4 times United Nations. That's represented this civil society. So I have spoken about to see in the 2007, there were UNCRP, United Nations Convention of Rights of Persons with Disability, and we have spoken about to add the blood-related disorder in the disability. So you see that it was India was the first signatory of that convention, and later on we rectified in 2008, and it was a long time the process of billing. Then it was finally became the Act, Rights of Person with Disability Act 2016. So there is I will be speaking about the Bihar state scenario. So I am not going to, already my background is not this, but I will tell you the different modes of the disabilities. Earlier, because it comes under the disability, so earlier it was the modes of like medical modes, different social modes, different modes are there, and see, United Nations adopted the Convention of the Rights of Persons with Disability on the 13th December 2006. See, and India was ratified the said convention on the 1st October 2007. So what was the principle? The principle was the respect for inherited dignity, individual autonomy, including the freedom to make one's own choice and independence of the persons. So there is a non-discrimination, then the full and effective participation and inclusion in society. Another is acceptance of the person with disability, in equality of the opportunity and accessibility, equality between men and women. So, as we know, there are 21 types of disability: locomotor disability, leprosy cured, cerebral palsy, dwarfism, muscular dystrophy, acid attack victims, blindness, low vision, deaf, hard hearing, speech and language disability, intellectual disability, a specific learning disability, autism spectrum disorder, mental illness, multiple sclerosis, Parkinson disease, then blood-related. This means hemophilia, thalassemia, sickle cell disease, and multiple disability. So just I will show you different types of disability. So this I am escaping this because already you have been spoken about this. So what I will be, I have shared one as compendium. Rajesh Sharma, will you? I had shared one as compendium. Will you just showing him here? Can we show? Oh, okay. See, I wrote 23 books regarding on the disability. So there are, as we know, person with disability and all the three blood related disabled people comes under disability. So as we know, there are that UDID. So any person from the India, they can type UDID. The link will come if the person do not have the certificate. So they can register themselves only. They have to have the Aadhaar card. They have to Aadhaar card. Once it has been logged into Ministry of Social Justice and Empowerment Department of Disability, that the person have to assign which hospital is nearer one. If suppose in the district Darbhanga is nearer one, so I have to put the Darbhanga. What happened in Bihar? None of the districts were found any sickle cell PWD. I have to tell PWD disease, SCD. And after intervention of mine, because I was the State Commissioner Disability, so what happened in the year 2016, 2017, 2018, till 2023, the Bihar government has identified 5 districts: West Champaran, then Siwan, then Purnia, Katihar, then another districts. All the tribal belt, Purnia, Katihar, and another districts, Nawada. So all are the tribal belt peoples are there. So we have started the diagnosis for we have planned for this year, because we are going to celebrate on 19th of this June, World Sickle Cell Day. So we are going to more awareness programs. So what are the rights are there? Just we want to share the people who are online or offline. See if the person with sickle cell disease, if he or she has any problem, like he is below poverty lines, if he does not have any land, there is under RPWD Act, under Section 37, there is a provision of providing 5% reservation for the person with disability. Madam was earlier telling that the reservation for 4%, but in the government job, it has not been provided for the blood-related disorder for the government job. So I am correcting that one. And for higher education, there is 5% reservation, but not in job so far. So we have to correct this one. For government job, there is no reservation for any blood-related disorder. We have to fight for that, for this rights. Oh yeah, okay. Okay, so
you continue to talk.
Yeah. So just I am showing one compendium. So I will be sharing the compendium. If you find any person with sickle cell disease, if he wants any facilities from government side, so there are the 102 sections are there. So under section 2, it has been defined about the definition of all 21 types of disabilities. Section 3 says there is any discrimination. Like what is the discrimination? The other disabilities are getting government job reservation for person with disability, but it has not been given to blood related disorder. So any person can go in the court. As you know, the State Commissioner for Person of Disability has been power of civil courts. So any person, if deprived with any rights, what are the rights? If there are non-equal opportunity rights, means that if the person having the sickle cell disease problem wants to go to school, books, it was the book. Yeah. Otherwise, you can go the website, na? Net is there. Yeah. Go. So anybody can download. Just type State Commissioner Disability. Go to internet. Anybody? Yeah, State Commissioner Disability Bihar. Go website. Yeah, this one. Yeah, this up. Yeah. This one. Yeah, this is the, you can see my photos are there. Yeah. Go down. No, home. Yes. No, it's not home. Yeah, contact. Yes. Go down. Yeah, this is a compendium. Books are there. You see the compendiums. Please download this compendium. This. Why I want to show the compendiums? If you have any problem, so you go through all the circulars are given. If any person needed ration card nahi hai, they go, there is a circular are there. They can get 35 kg of ration per month. अगर उनको शादी करना है, in Bihar there is a 3 lakhs. There is one person is PWD, then gets 1 lakh. Mukhyamantri Nisaksan Prosahan Yojana. Agar both person are PWD, then another 1 lakhs. If intercaste, there is another 1 lakh. So 3 lakhs. They can get benefit. Same as if the person needed battery, like sickle cell disease person, they have the problem in mobility. If they want any vehicles, battery motorized vehicles. So in the Bihar, what we made, only 60% disability will be there, then they can get the battery motorized vehicles without any cost. Another thing, like I am also, you might be knowing, the chairman of Selection Committee of Paralympic Committee of India. So I was told you that I have been 60 country represented in either in the United Nations as well, research paper as well as Paralympic, Special Olympic, Deaf Olympic and blind sports also. So if any person is good in the sports or any the drawing, paintings or any other academic performance, he need any accessibility, means any devices. If his price is 60 lakh, 40 lakh, 70 lakh, whatever. So government will provide 75%. The water is the price is there. Yeah. So we'd like to show this. Yeah, all the it is given. It is Hindi. All the what are the sections are there, and how will we getting the benefits, and what are the circular are there. It is a hyperlink also. In every page you will see the hyperlink. So you can click the hyperlink, you get original circular. I will show you. Suppose recently we had conducted the election. If any person with sickle cell diseases has given the election duty. So there is a provision, they can eliminate his name from the election. All the provisions are there. If he wants to NHFDC loan, he wants to 25 lakhs loan. Do you know NHFDC, any person? National Handicap Finance Corporation Limited. So government gives till 25 lakhs loan. So whatever the benefits are there, every person with sickle cell disease will see. These are the letters I will show you. This see. Nyale has all the every down there is a hyperlinks are there. So all the circulation are any discrimination. Suppose any person with sickle diseases have any problem with the legal problems, means उनके आसपास कोई उनको प्रताड़ित करता है, उनको बोलता है, जैसे somebody was telling कि हमको बोलता है, देखने से बोलता है कि किसी तरह का डिस्क्रिमिनेशन है. सो देयर इज ए प्रोविजन. अगर कोई उनको सिकल सेल कोई खराब वर्ड से बोल दिया तो देयर इज ए ऑफेंसेज एंड पेनाल्टीज. 6 महीने का मिनिमम जो है उनको जेल हो सकता है और मैक्सिमम जो 6 साल तक का है. पेनाल्टीज है 10,000 to 50,000. So all what are the circular, all the judgments you will find there are the various judgments. All it is given. What are the benefits you will be getting? Every section, all the, see suppose in the Gujarat there is a most Gujarat, then Chhattisgarh, Jharkhand, Odisha. उनके बजट किसी मान लीजिए कटक में उनका म्युनिसिपल कॉर्पोरेशन का बजट है 100 करोड़ का. तो हाउ विल गेट द बेनिफिट्स? देयर इज ए प्रोविजन ऑफ 5% बजट विल बी फॉर एनी डेवलपमेंट पर्पस. आइदर मेकिंग द रोड बनाना है, हाउस बनाना है, म्युनिसिपल कॉर्पोरेशन किसी चीज का काम कर रहे हैं तो दे विल सी कि 5% उसका बजट पर्सन विद डिसेबिलिटी के लिए खर्च हो रहा है कि नहीं. अगर इस खर्च नहीं हो रहा है तो व्हाट दे विल डू, लाइक आवर सी इन द our website, what is there? Online complaints. See, you will find there is a, see, there is a chief commissioner of person with disability, Government of India. See, it's a given voice complaint, online complaint. So whatever the complaint you will be given, just आप अपना उनका आधार का ये डिसेबिलिटी सर्टिफिकेट लगा दो. ये सिविल कोर्ट के पावर होते हैं, सुमोटो पावर भी हो सकता है. अगर आप डिसेबल नहीं है, आप काम करते हैं, डॉक्टर्स हैं या सोसाइटी, अगर आप भी लिख कर दे दोगे तो इज द पावर ऑफ द स्टेट कमिश्नर टू टेक सुमोटो. तो ऑल द ऑर्डर्स आर देयर. सी द ऑर्डर्स, एवरीथिंग्स आर देयर, नोटिफिकेशन, एवरीथिंग. सो यू कैन गो थ्रू दिस website also in the compendium. These are more than 560 pages compendiums are there. I will already given to Rajesh Sharma ji, so you will be getting this. So whatever the benefits from government side for making the certification, आपका dignity है, आपको पढ़ाई करना है, आपको आवास चाहिए, मान लीजिए खाने के लिए नहीं है तो फूड सिक्योरिटी से 35 kg उनको अनाज मिल सकता है. जॉब के लिए ठीक है, इसमें बट Section 35 says 5% reservation in private sector also. And Bihar was the first state. मैंने एक सर्कुलर जारी किया था, जितने होटल्स हैं, जितने इंस्टीट्यूशन हैं, जितने प्राइवेट ऑर्गेनाइजेशन हैं, जितने इंडस्ट्रीज हैं, आपको 5% पर्सन विद डिसेबिलिटी को रखना होगा. तो ऑलरेडी वो रख रहे हैं. ट्रेनिंग जो वोकेशनल ट्रेनिंग है, देयर इज ए प्रोविजन ऑफ 5% रिजर्वेशन है. उनके आने जाने के लिए देयर आर कंसेशन, बट इज नॉट फॉर द ब्लड रिलेटेड डिसऑर्डर. उनके डिसेबिलिटी रेलवे कंसेशन इज नॉट देयर, बट डिफरेंट मेडिकल साइट से बनते हैं जिसकी जानकारी मुझे नहीं है. बट डिसेबिलिटी साइट में अभी तक रेलवे कंसेशन नहीं है. तो आप लोग काम करते हैं, यू शुड फाइट फॉर CCPD, चीफ कमिश्नर ऑफ डिसेबिलिटी के यहाँ आप सिकल सेल वाले एक लिख कर दो, हमारे रेलवे कंसेशन क्यों नहीं है, हमारे लिए जॉब क्यों नहीं है. क्योंकि नॉन डिस्क्रिमिनेशन, सेक्शन 3 सेज देयर इज नॉन डिस्क्रिमिनेशन. तो मैं आप जो पर्सन विद सिकल सेल डिजीज हैं, मैं उनको बोलना चाहूँगा कि आप कम से कम जो है इसमें दो. बिहार वी डिड नॉट गेट एनी सिंगल PWD विथ सिकल सेल. हमारे यहाँ कोई मिला नहीं है. अगर हम लोग बट गवर्नमेंट वांट्स टू स्क्रीनिंग, आपका मदद चाहिए। मैंने देखा है उड़ीसा, गुजरात, हम आपको बिहार बुलाना चाहेंगे। मैंने पहली बार अटेंड किया हूँ, तो निश्चित रूप से वो काम करते हैं। यू कम बिहार। लेकिन बिहार में अभी तक एक भी सिकल सेल डिजीज का कोई हमारा पेशेंट नहीं मिला है। अगर आपके नॉलेज में है, प्लीज शेयर विथ अस, सो विल डू समथिंग। बट स्क्रीनिंग के लिए 6 स्टेट में हम लोगों ने काम कर चुके हैं। बट बिहार की आबादी है 13 करोड़, और हमारे 38 डिस्ट्रिक्ट्स हैं। हमारे यहाँ एक और अच्छा चीज है कि एवरी डिस्ट्रिक्ट वी हैव असिस्टेंट डायरेक्टर डिसेबिलिटी। हर एक जिले में हमारा एक जो है डिसेबिलिटी ऑफिसर्स हैं, हर एक जिले में। बिहार है, उत्तर प्रदेश है, आई एम नॉट नोइंग अदर स्टेट कि किसी स्टेट में डिसेबिलिटी ऑफिसर्स जिले लेवल पर हैं, हमारे बिहार में हैं। तो मैं धन्यवाद दूंगा। मैं, अगर आपको मेरा नंबर है ही, कोई पर्सन विद डिसेबिलिटी, दे ऑल 21 टाइप्स इंक्लूडिंग ब्लड रिलेटेड डिसऑर्डर, उनके गवर्नमेंट साइड से क्या बेनिफिट मिलने वाले हैं हम आपको बताएंगे। और मेरा नंबर भी आप शेयर कर दीजिए। उनको सर्टिफिकेट नहीं बन रहा है, उनको घर नहीं है, उनको ज़मीन नहीं है, उनको असिस्टेड डिवाइस चाहिए। मैं ICMR के साथ एक बैठक किए थे 80 असिस्टेड टेक्नोलॉजी के ड्यूरिंग द कोविड पीरियड। उनको कुछ हो सकता है, हमारा सिकल सेल डिजीज है, उनको लोकोमोटर प्रॉब्लम हो जाता है। रिसेंटली वन केस गॉट कहीं और का, उसको सिकल सेल डिजीज हुआ था, उनको लोकोमोटर डिसेबिलिटी सर्टिफिकेट बना दिया। बाद में रेलवे वाले ने पता चला कि वो तो सिकल सेल डिजीज है, उनको वहाँ जॉब नहीं मिला क्योंकि उनको सर्टिफिकेट बना दिया गया था लोकोमोटर डिसेबिलिटी का। तो दैट आल्सो कि उनको अगर सिकल सेल है तो लोकोमोटर डिसेबिलिटी विथ सिकल सेल, इट कम्स अंडर मल्टीपल डिसेबिलिटी। तो मैं इस तरह के बेनिफिट से, जो भी उनको बेनिफिट चाहिए, कहीं जाना हो, आना हो, अभी हायर एजुकेशन में देयर इज 5% रिजर्वेशन, विदेश में पढ़ना चाहते हो आप, उसके लिए मिनिस्ट्री ऑफ सोशल जस्टिस एम्पावरमेंट ऑफ डिसेबिलिटी आपको पैसा देती है। रिसर्च करना चाहते हो तो देयर आर, जितने भी आपके 42 डिपार्टमेंट्स हैं, चाहे आपको मनरेगा से काम चाहिए, आप किसान हो तो किसान का सुविधा चाहिए, आपको आवास का सुविधा चाहिए, आपको पशुपालन का सुविधा चाहिए, आप फिशरीज करते हैं उनकी सुविधा चाहिए, कहीं आप जाते हैं मान लीजिए आपको अस्पताल में, तो आपको पहले आपको आपके बच्चे को, आपको फैमिली को पहले उनको देखना है। एवरीथिंग इज गिवन इन द राइट्स ऑफ पर्सन विद डिसेबिलिटी एक्ट। देयर आर 102 सेक्शन 89 to 95 देयर इज ऑफेंसेज एंड पेनाल्टीज। स्टेट कमिश्नर के पास पावर है उनको पेनाल्टीज देने का, और हर जिले में देयर इज ए स्पेशल कोर्ट। आप जानते हैं हर जिले में स्पेशल कोर्ट है और स्पेशल PP पब्लिक प्रोसिक्यूटर ऑफिसर है। आपको प्रॉब्लम हो रहा है, आप अपने जिला विधिक सेवा प्राधिकार के पास जाओ, एक आप लेटर लिख दो कि हमको ये डिनाइल कर रहा है, बस कुछ नहीं है, आपको मुफ्त में लॉयर मिलेगा। और जैसे कि SC ST का कोर्ट है, उसी तरह इनका एक कोर्ट है, उसको बोलते हैं स्पेशल कोर्ट, सेक्शन 84 ऑफ RPWD एक्ट। तो मैं इसलिए बताना चाह रहा हूँ कि ये खाली सिकल सेल डिजीज नहीं, ऑल 21 टाइप्स ऑफ डिजीज, और हर परिवार में एक ना एक डिजीज PWD है। कैसे? आफ्टर 60 ईयर्स कम सुनाई देता है, कम दिखाई देता है, मोबिलिटी प्रॉब्लम है, पार्किंसन डिजीज है, हर 60 कहीं ना कहीं हर फैमिली देयर इज ए PWD। सो मैं आते समय डॉक्टर पंडोरकर से बहुत धन्यवाद दूंगा कि मेरा पार्ट जो है रिहेबिलिटेशन का, गवर्नमेंट से बेनिफिट दिलवाने का, आपको कहीं भी हो सर्टिफिकेट बनाने का हो, कहीं भी हो, तो निश्चित रूप से स्टेट कमिश्नर डिसेबिलिटी आपके हर स्टेट में है, आप उनका बेनिफिट लीजिए। और मुझे बुलाया उसके लिए बहुत बहुत धन्यवाद। कोई क्वेश्चन हो तो आप पूछ सकते हैं।
जरूर, थैंक यू वेरी मच। अपन इसके बाद बात कर लेते हैं, बिकॉज 5 बजे विल हैव टू क्लोज। जो लोग सुन रहे हैं, हाँ प्लीज।
मैं बोला हूं ना, चीफ कमिश्नर ऑफ पर्सन विद डिसेबिलिटी, अभी आप सर्च करो, आप एक केस फाइल करो, तो उसके लिए PWD को होना जरूरी, उनका किसी का सर्टिफिकेट लगा के करना होगा। अदरवाइज यू गो, हमारे हाई कोर्ट में जा सकते हो, PIL दर्ज कर, सुप्रीम कोर्ट में दर्ज कर सकते। एवं ट्रेवल रेलवे कंसेशन भी आपके पास नहीं है। उन दोनों के लिए मैं चाहता हूं कि आप लोग आगे आए, खासकर किसी का भी आप डिसेबिलिटी सर्टिफिकेट लगा के आप PIL करो तो निश्चित रूप से हो जाए। कि रिसेंटली इट हैज बीन एडेड।
सर अपने को वही मुद्दा यह है कि नहीं किया गया कोई बात नहीं, मगर अब करवाने के लिए हमें प्रयास करना पड़ेगा, हो जाएगा।
Yes.
बट कोशिश तो करें हम। So nobody has brought this matter before. If we bring the matter, I am sure there are people like him who will help us. Thank
Okay,
you.
Thank you. बुध गया में। Okay, so let us inform because government says कि हमारा बिहार में कोई जो है हमारा नहीं सिकल सेल डिजीज है। अगर आप बताएं तो फिर हम लोग उस पर काम करेंगे। बहुत बहुत धन्यवाद।
Sir, बहुत बहुत धन्यवाद. Thank you very much. So we really got a lot of insight into how much rules, regulations are there. Our next presentation is by expert, eminent transplant specialist, Dr. Gaurav Kharia from Apollo Hospital. With a large experience, he is working on treatment, on research, and many aspects of sickle cell. Gaurav, please.
अच्छा एक बार ये तो नहीं लगाना है। We need to put this, move the slide. Otherwise नहीं है तो you can use this. Yeah. Good afternoon, everyone, and thank you, Dr. Pendakar sir, for having me here today. This is a very sort of important and I would say pertinent meeting with respect to the month which we are currently, living in. June is more so celebrated across the globe as World Sickle Cell Month, and more so June 19th is coming, which is the World Sickle Cell Day. So this is a very pertinent meeting, and this is something which was quite a neglected disease till I would say around 5 or 7 years back, or maybe a decade back. But for past 1 or 2 decades, sickle cell disease fortunately has gained a lot of attention, not only in India but across the globe. So in majority of the meetings where we go nowadays, sickle cell disease is something very, very important, and especially the curative options for sickle cell disease. So I'll be taking you through the work which I have done for sickle cell disease in past, say, 10 to 12 years. So I've spent almost quarter of my life working dedicatedly for coming up with curative options for sickle cell disease. And curative options doesn't mean, when we talk about transplant, it is very different doing a transplant in Europe vis-a-vis America, vis-a-vis India, because the kind of patients which we see are very, very different. So what I'll do is I'll just take you through these brief history of sickle cell disease, because it's very, very interesting. It's not a very old disease. It's a disease which is just a century old. And then subsequently, I'll take you through the epidemiology. It has already been discussed in the previous slides, but what's the global sort of burden of sickle cell disease? How is it going to evolve in next 20 to 25 years? Pathophysiology, current therapeutic modalities, transplant background, what our experiences with respect to transplant for sickle cell disease, our experience of more than approximately 140, 150. By now, it is more than 160 transplants for sickle cell disease. Then finally, I'll sum up and we'll move on to the question answer session. So sickle cell disease is not a very old disease. As I said, it's the first sort of appearance or identification of sickle cell disease dates back to 1910 when a famous US physician noticed some weird findings in the peripheral smear of one of his patients also who was a medical student and he hailed from African descent. So he noticed very weird findings which he initially attributed to some sort of biochemical reaction, but he repeated this multiple times and subsequently he attributed, and the same findings were observed. So he attributed that this is some new pathogenomic disease, and subsequently Professor Linus Pauling, Dr. Linus Pauling, who was a famous chemical biologist in the US, he gave the molecular character or molecular nature of sickle cell disease. And later in that decade, Dr. V.S. Ingram, he further categorized that how is this sickle cell disease molecular structure of sickle cell disease, or the hemoglobin of sickle cell disease, molecular sort of makeup of sickle hemoglobin is different from other forms of hemoglobin. So these were very, very interesting findings for a new disease. Now, as all this was happening, a pediatrician by the name Dr. Janet Watson, who was working in Brooklyn, New York, while practicing, she noticed that the kids who are born with sickle, or mothers with sickle cell disease, somehow in the initial years of life, even if they turn out to be like sicklers eventually, in the initial years or initial first year of life, they are relatively protected against sickle related complication. And she at that time hypothesized that this might be due to some different hemoglobin which is there initially in the sort of newborn period and also in the infancy, and subsequently that form of hemoglobin disappears, and that's why these patients become more symptomatic. And later on, this was further confounded by the study, large scale study done in approximately 15,000 patients and published in NEJM, and it very clearly demonstrated that the hemoglobin which she mentioned or highlighted was the fetal hemoglobin, and it was documented that if a child has more than 8.6% fetal hemoglobin in his blood, the relative chances of having sickle-related complications are much, much less. I would also like to mention about the work done by one very famous, sort of not so famous, I would say. That's a pity because not many people know him, but he has made some immense contribution to the field of hematology, especially the red cell disorders. So he's Dr. V.S. Ingram. He's a pediatrician and pediatrician turned researcher working in Dana-Farber Institute, Boston. And he was the one who actually documented that why this switch of hemoglobin happens from embryonic hemoglobin to fetal hemoglobin and subsequently to adult hemoglobin. Which was previously unknown. And apart from this, he also highlighted the importance of this particular locus, which is BCL11A. And some of you might be aware that this BCL11A locus is one of the most important locus on which the subsequent very futuristic sort of gene therapy work is being done. So he made some very, very important contributions to the field of hematology, especially hemoglobinopathies. Now, looking at the global burden of disease, Garima has already highlighted this. So the burden of the disease globally is more in the areas where there's endemicity of malaria, and she has already highlighted the importance. Why is it so? Now, this is a very important slide. So we all are trying to control a disease or to bring it down, bring down the burden of the disease. But what is the actual picture? Now, these are the cardiograms which very clearly show that the burden of the disease, top is the cardiogram which shows the burden of the disease in 2010 and bottom is 2050. So even if we start making a full throttle efforts today, then also the disease will plateau down only after 2050. Okay, so still a lot has been done, and we are targeting to eliminate sickle cell disease by 2047. Okay, and so leave aside elimination. If we start making full-on efforts, then by 2050 we'll be able to plateau down this disease, which is currently on a increasing trend. So that's why it makes very, very relevant to talk about this particular disease. Now, pathophysiology, we all know it's a small base pair, single base pair mutation which leads to formation of defective messenger RNA. This defective messenger RNA forms a defective protein, and this defective protein is sensitive to oxidative stress, and in the state of oxidative stress, it turns it modifies its shape and turns into sickle shape, which subsequently leads to the complications related to sickle cell disease. The complications are broadly categorized into hemolytic complications and vaso-occlusive complications. Now, some patients, as we might have seen in different parts of the country, some might have predominantly hemolytic manifestation behaving more like thalassemia. Some might have, veno-occlusive manifestations behaving like a typical sickle, and some have a mixture of both of them. So in different parts of the state, I regularly go to Chhattisgarh, I regularly visit Madhya Pradesh, and we see very sort of variable manifestations in different patients. Now, current therapies, so supportive care, which includes like these essential medicines, penicillin, hydroxyurea has already been highlighted. Then vaccination. It is very good to know that the few very important vaccinations such as pneumococcal, meningococcal have already been included as a mandatory vaccination for sicklers in few of the states. Then chronic transfusion and chelation for patients who behave more like hemolytic anemia, hydroxyurea, voxeltor and crizan. So all these curative approaches. There are only two curative approaches. One is transplant, which is a sort of a standard of care as of now, and the another one is gene therapy, which is also approved by FDA. But for us, it's I would not say a very long way, but it's a relatively sort of long way. It will take another 4 or 5 years to come up with indigenous cost-effective gene therapy solutions, which we and a number of our colleagues across the country are very aggressively working on. So the first report of transplant for sickle cell disease dates back to sort of 1996, when a young girl who was suffering from acute myeloid leukemia, so it's a blood cancer. So she underwent a transplant to cure acute myeloid leukemia, but eventually it was noticed that she was cured of her sickle cell disease as well. So this was a very important finding, because this gave a thought that, okay, if transplant can be used as a curative modality for sickle cell disease per se as well. So subsequently, this is the EBMT Eurocod data till 2013, which shows that approximately around 1,250-1,300 transplants were done till 2013, and after that another, I would say 1,200-1,500 transplants have been added. So till date, across the globe, around 3,000 transplants have been done for sickle cell disease, which is a very, very minuscule number. What is the number of sicklers born each year in the country? A rough estimate in India? So around 30 to 40,000. Across the globe, around 3 to 4 lakhs. It was highlighted in the previous slides. And the number of transplants which have been done in past 30 years, just 3,000. So a very, very minuscule number as compared to the number of patients who actually need this modality. Now, transplant for sickle cell disease is an unmet need. And why I'm saying this is, more than 140,000 patients with sickle cell disease live in Europe and USA. Approximately 40,000 patients, they have the indications for transplant, I mean established indication, but unfortunately, because of one or other logistic factors or the donor availability is not there, they are not being considered for transplant. And if we include the other areas like African continent or Middle East, Indian continent to this number, then the numbers of patients who actually need transplants is huge. What is the current? Every year, roughly we do 100,000 transplants for different diseases. But as I highlighted, till date for sickle cell disease, only 3,000 transplants have been done, which is a pity. But the main reason for this was that it was a neglected disease. Before 1996, it was not even known that a transplant can be offered as a curative modality for sickle cell disease. So in past 10 to 15 years, a lot of interest has been generated, and that's why a lot of work has been done for transplants for sickle cell disease. So why is this difference? in the actual numbers of patients who need transplant and the number of patients who have been transplanted. So there are various factors which I have understood by working in sickle cells community closely for past almost 10 to 15 years. So one is lack of clear-cut indications. Still, a lot of our physicians, pediatric colleagues, they don't know that who are the actual patients who need transplant. Lack of awareness, information amongst the physician, parents, and patients. Lack of funds, which becomes a very important factor. But various state governments and the central government have taken some very concrete steps to help these patients financially to undergo transplant. And Chhattisgarh is one beautiful example which is supporting a number of patients who need transplant for sickle cell disease. And the lack of availability of donor, but I would say this problem has been addressed to a significant extent. Now, this is one very important slide because earlier the indications were, I heard in one of the previous presentations by Dr. Anil. So the thought was that only the very severe phenotypes need to be transplanted. Okay. But what we have observed over a period of time that the patient, once a patient reaches that stage, when the patient is very symptomatic, very severe, and then we offer a transplant, the outcomes are pathetic, very poor outcomes, and then that I'll show you in subsequent slides. So now the bottom line is that the pediatrician or the physician should follow these patients up very closely, put them on optimal supportive care with hydroxyurea, folic acid, and other things, and identify the cohort of patients who are symptomatic even after being in optimal supportive care. And these are the patients who need to be transplanted early for the best outcomes. So these are the indications. And if you go through the indications, I would say almost 30 to 40% of our patients fulfill one of these criteria. And these are the latest revised indications used globally as transplant indications for sickle cell disease. Now, if you look at the global data for sickle cell disease, this was a CIBMTR. CIBMTR is one sort of big consortium for transplant across the globe. It is mainly US-centric. So they looked at the database of around 1,400 transplants done for sickle cell disease, and out of which around 900 patients were analyzed and based on the different categories. So when we do a transplant, we need to have a donor. The donor can be HLA identical sibling donor, or a HLA identical unrelated donor, or a mismatch family donor. When the matching is not 100%, it is called as a mismatch family donor. So they observed that the outcomes of HLA identical sibling donor transplants are very good. Okay, so they were doing, the success rates were approximately 90% or so. But the problem areas were the patients who were undergoing transplants for unrelated donor transplants or haploidentical transplants, which is a bigger number. Now, if you look at the data from Europe, so again, if we look at the alternate donor transplants, alternate means the patients who do not have a HLA match family donor. So if you look at these patients, again, the outcomes are very poor. So this was one felt need that the patients who need a transplant, unfortunately, only 25% will have a HLA, or even 20% will have a HLA identical donor in the family. Rest 80% will not have. When we look at unrelated donors, unfortunately, because of the poor representation of ethnicities where the sickle burden is high in these registries, it is very difficult to find an unrelated donor also. So if we compare it with thalassemia, the chances of finding an unrelated donor is very high. But to find an unrelated donor for sickle cell disease for patients from Middle East or from Africa or from even India is relatively a challenging task. So we are left with only one option, which is a haploidentical transplant. Now, the initial report of haploidentical transplant for sickle cell disease was in 2012. Okay, so this group in US, they chose around 14 patients with very severe symptoms and took them up for transplant because they did not have haploidentical transplant, as these patients did not have HLA identical donor. And they showed that, okay, these almost 50% of these patients can be cured of sickle cell disease. So this was a very interesting paper and interesting observation, and it paved the way for subsequent work which was done by different groups across the globe. So if I just take you through our sickle cell journey over past 10 years, so I got trained here and then went to UK and then specially worked in sickle cell disease for almost a year at Imperial College London, and then I came back with the intent that okay, I will take this work forward in India. So after coming back in 2014, I did my first transplant, which was actually identical donor transplant from African continent, and this child is now more than 10 years post bone marrow transplant, doing very well. The same year, we got another patient from Africa, a very symptomatic child, underwent a half mesh transplant using father as a donor. So again, this child is also doing very well, almost 10 years post bone marrow transplant. So when I was working at Imperial College, this was the standard, this was the protocol which we were using, which was a bit different from the initial protocol which was used by the Americans. So we made some modifications at Imperial College in the protocol to optimize the outcomes, to increase the success rate of transplant. So when I came back, I used the same protocol, but unfortunately, our patient cohort was different. We used this protocol. This did not work as good as it was working in UK. I made the second round of modification, which improved the outcomes, but not to our expectations. So we made further modifications with this intent to minimize the rejections, to minimize graft versus host disease, and obviously the bottom line was to have better overall survival and event-free survival. So this was the protocol which we finally developed, which is called as the Apollo protocol, and it's a very intense protocol, and the preparation starts from 2 months before the transplant, 2 to 3 months before transplant, and the follow-up is stringent follow-up is till day 100 post-transplant and subsequently till 1 year post-transplant. We published our initial results, very encouraging results. Graft failure rate was almost zero. Some complications which are very usual in transplants, nothing different from what was reported by other groups. And if I take you through the overall survival, so the GVHD, which is one important complication, so GVHD rates were also very less than 20%, grade 2 to grade 4 GVHD. If we talk about grade 3, grade 4, it was less than 10%. Chronic GVHD also was very, very less. So very satisfying results with this modification in our patients, which are unfortunately very, very severe as compared to, because what happens in Europe is they are very well managed. I mean, their transfusion practices are fantastic, their exchange transfusion are fantastic, optimal doses of hydroxyurea, but unfortunately the patients which we cater are not that well managed, and that leads to a number of challenges during transplant. So with this protocol, we were able to give very good outcomes, close to 90% in half mesh transplant. Matched sibling donor transplant, we are already doing very good. This was half mesh transplant, which was the requirement for almost 80% of our patients because of non-availability of HLA identical donor. Then just taking you through our overall experience. So this is the data of around 140 transplants so far. So a mixture of haploidentical transplants, half mesh transplants, and HLA identical donor transplants. So I'll just take you through the outcome. So this is the overall survival. So if we see the overall survival in sibling donor transplants, age ranging 10 months till 32 years is around 91% at around 1100 days. This is now more, around 1250 days. Whereas in haploidentical, it is approximately 74%. So haploidentical transplants, we need to optimize further, which we have done, because this is a combination of the first strategy which we use, second strategy, and the third modification. So obviously the outcomes on with third modification are much better. So with the modifications which we made, the rejection rates, as we can see in the other slide, the rejection rates have come down to almost 0%. We have faced 1 or 2 rejections in the recent past, but they are probably because of some other factors. Now, age, as I highlighted, is one very important factor. So if we see divide the patients into more than 13 years who underwent a transplant with less than 13 years, there's almost 25 to 30% difference in the outcome. So if we pick these patients early, and if we transplant them early, when the end organ damage has not happened, the outcomes of transplants are the best. If we look at the overall survival based on age and type of transplants, so if we have a HLA identical donor less than 13 years, the outcomes, successful outcome is approximately 97-98%, vis-a-vis if we have a patient who's, if it is more than 13 years, then it comes down by 10%. In haploidentical transplant, this difference is approximately 60% and 85%. So with the modifications which we have made, the GVHD rates are also very acceptable. No significant complications. These are very usual complications. CMV reactivation post-transplant, BK reactivation. The viral reactivations are very, very common. And we haven't seen that with the modifications which we have made to meet the needs of our patients, it has added to any further complications, or whether it is increased risk of infections or any other complications. Immune reconstitution is one important aspect, because that is what decides how the patient will perform, what will be the risk of infections post-transplant. So using this particular protocol, the immune reconstitution has also been very, very acceptable, which in turn reduces the risk of infections. So based on the success of our haploidentical transplant protocol, which was the Apollo protocol, we thought let us use the same strategy for our HLA identical donor transplants as well, because haploidentical transplant was going extremely well. It was very well tolerated. So we initially did it on 4 patients, including thalassemia and sickle cell disease, got very encouraging outcomes. Then we extended it further. Now we have done it in approximately around 56 to around 60 patients, both thalassemia and sickle cell disease, HLA identical donor transplants using this protocol which we have used. And as we can see that the outcomes are very encouraging. This is a previous slide. This is a little bit old slide. The graphs have come down a little bit, but still the outcomes are approximately 94-95%. So summary of our learning: HLA identical donor transplant is the preferred donor. Success rate of haploidentical donor transplant is increasing day by day and approaching close to HLA identical donor transplant. We have addressed the challenges of graft failure to almost 100%. Graft versus host disease rates have come down to less than 5 to 10%. Age is a very, very, very important factor. So we should try to identify these patients who are symptomatic even after being on optimal supportive care, and take them for transplant early. Infections remain a challenge, which we are trying to address further, and we are trying to optimize our protocol further so that we can improve the outcomes even more in future. So if we come to the basic question that whom to transplant and when. So as in all non-malignant diseases like thalassemia or other diseases, transfusion-dependent anemias, for best outcomes, transplant in sickle cell disease should be performed when a recipient is at a good functional baseline in anticipation of inevitable organ damage. Okay, what it means is, suppose if we take the patient up for, we identify that the patient is on optimal doses of hydroxyurea at around 4 or 5 years, still the patient is very symptomatic, still having 3 episodes of veno-occlusive crisis every year in 2 consecutive years, requiring transfusions or other set of indications which I showed earlier. These patients should be taken up for transplant early, because if we wait for organ damage, that okay, this patient develops a stroke, then I'll take the patient up for transplant, or if he develops renal dysfunction, then I'll take this patient up for transplant. So with single organ damage, the outcomes come down by 10%. With end organ damage, the outcomes come down by around 20 to 25%. So to conclude, sickle cell disease is a preventable disease. We should do everything possible to prevent this disease. Unfortunately, even if after taking all the necessary precaution, a child is born with sickle cell disease, as soon as the diagnosis is made, these patients should be started on optimal supportive care. And we have already seen what is optimal supportive care. A close observation is required to identify CFA phenotypes, and transplant should be offered to these CFA phenotypes in early years of life to have the best possible outcomes. And as we make bone marrow transplant more amenable to the masses with the help of all of you and from Government of India and various state governments, we should also prepare ourselves for future modalities such as gene therapy, which we are actively working on to come up with affordable and effective gene therapy solutions which are indigenous to the country. Thank you very much. Yes, please. Yeah. This is a very pertinent. So basically, in the initial years of life, so like 2014 to say 2018, 2019, majority of chunk was African patients. But in past 4 to 5 years, there's a lot of interest, and as I said, I regularly go to Chhattisgarh and Madhya Pradesh, and believe me, in every OPD, if I see 3 or 4 patients with thalassemia, I see around 25 to 30 patients of sickle cell disease in a very, very bad shape. So in past 3 to 4 years, the awareness is increasing in our country, and the number of patients who are opting for transplant is also increasing. At this point of time, also we have around 3 or 4 patients from Madhya Pradesh and from Chhattisgarh undergoing transplant at our center. Yeah, so no, I mean, it's not about approval. Look, Plexifer is the standard mobilizing agent for gene therapy. Now, if it can be used for gene therapy, why it cannot be used for, rather, if you look at the way Plexifer works, it is a much safer molecule as compared to GCSF, okay? So for all our patients, we use a combination of GCSF and Plexifer, and that's a different aspect. So if you look at the protocol, our Apollo protocol, it includes mobilization with GCSF and Plexifer in all the patient, irrespective of whether it's a poor mobilizer or a good mobilizer. Because what we have seen is that use of Plexifer bring down the level of CD3 count by almost a log, which in turn reduces the risk of graft versus host disease.
Thank you.
Thank you very much, Dr. Gaurav. If there are no questions, I will request Dr. G.K. Rath to felicitate Dr. Gaurav.
Thank you.
Dr. Garima. Thank you, sir. So now I invite Dr. Lalit Pargi from Udaipur.
Yes, I can. मेरी छोटी सी जानकारी, ललित किशोर पारगी, फाउंडर मेंबर, सिकल सेल सक्षम राजस्थान फाउंडेशन, एग्जीक्यूटिव मेंबर, नेशनल अलायंस ऑफ सिकल सेल ऑर्गेनाइजेशन, नास्को, कमेटी, स्टेट कमेटी मेंबर हूँ, सिकल सेल वर्किंग कमेटी राजस्थान गवर्नमेंट का। ये इंडिया में जो प्रिविलेंस है वो इस तरह से है। मैं राजस्थान की बात करूँगा। Prevalence of Rajasthan in sickle cell disease. Information about sickle cell disorder in Rajasthan is limited and reported to be prevalence in tribal population area. Sickle cell trait has been reported for all 8 districts dominated by the tribal population Udaipur, Banswara, Sirohi, Pratapgarh, डूंगरपुर और पाली, सिरोही, राजसमंद भी इंक्लूडेड हैं इसमें। The prevalence of sickle cell disease is 9.2% in similar to the reported from Odisha or Maharashtra between 5.5 to 16.5. Sickle cell disorder is reported in all major tribal गरासिया, मीणा, भील्स, डामोर. After the National Sickle Cell Elimination Mission 2047, जो राजस्थान की जो 8 डिस्ट्रिक्ट जिनको इंक्लूड किया गया है सिकल सेल मिशन में, हमारा करीबन जो टारगेट पॉपुलेशन हो 45 लैक्स के अराउंड है, जिसमें से अभी 70 से 80% के अराउंड स्क्रीनिंग हो चुकी है. और हम अभी फ़िलहाल हमारी बिगनिंग है राजस्थान की, क्योंकि राजस्थान में पहले 2 साल पहले इतना सिकल सेल के बारे में पता नहीं था. तो हमें पिछले साल ही सेंटर ऑफ एक्सीलेंस फॉर सिकल सेल डिजीज़ जो RNT मेडिकल कॉलेज उदयपुर में मिला है, वहाँ जिसे डिक्लेयर किया है 10/2/2023 को. हमारे वहाँ पे जो अवेलेबल फैसिलिटीज़ हैं वो न्यूबॉर्न स्क्रीनिंग है जो चल रही है, करीबन NHM के थ्रू चल रही है, और उसमें 17,000 से ऊपर करीब 18,000 स्क्रीनिंग हो चुकी हैं, जिसमें से 247 बेबीज़ जो पॉजिटिव आए हैं. उसमें डिफरेंट टाइप के जो वेरिएंट है वो आए हैं, जिसमें सिकल सेल, सिकल विद बीटा है, सिकल विद HBD है, और सिकल विद E है. साथ ही हमारे पास स्क्रीनिंग फैसिलिटी RNT मेडिकल कॉलेज में अवेलेबल है, जिसमें हम लोग अभी तक करीबन 300 के अराउंड पेशेंट हम लोगों के पास हैं, और 1000 के आसपास हम लोग ट्रेड को डायग्नोस कर चुके हैं. हमारे पास वैक्सीनेशन की फैसिलिटीज है जो मिनिस्ट्री ऑफ ट्राइबल के सपोर्ट से हमें प्रोवाइड की गई है, जिसमें निमोकोकल, मेनिंगोकोकल, इन्फ्लुएंजा, ये सभी वैक्सीन हम लोग प्रोवाइड कर रहे हैं. हमारे इस सेंटर ऑफ एक्सीलेंस से हम मोबाइल कैंप्स और आउटरीच एक्टिविटीज़ कर रहे हैं. ये हमारा सेंटर ऑफ एक्सीलेंस है जो वैसे तो एक कमरे में सीमित है, पर फैसिलिटी में हमारे यहाँ पे सभी तरह की फैसिलिटीज़ हैं, और हमारा ट्रांसफ्यूजन और VOC मैनेजमेंट वार्ड अभी इस्टेब्लिश किया गया है. राजस्थान के 8 डिस्ट्रिक्ट में अभी तक जो सेंटर है हमारा वो उदयपुर में ही इस्टेब्लिश हो पाया है. मैं अपने बारे में बताना चाहूँगा. हम लोग जिसमें वर्क करते हैं वो हमारा फाउंडेशन है सिकल सेल सक्षम राजस्थान फाउंडेशन, जो ओनली एक ऑर्गेनाइजेशन है जो राजस्थान में सिकल सेल पे वर्क करता है. साथ ही ये नॉन प्रॉफिट ऑर्गेनाइजेशन है. हमारा जो ऑर्गेनाइजेशन है वो नेशनल अलायंस ऑफ सिकल सेल ऑर्गेनाइजेशन के साथ हमारा मदर ऑर्गेनाइजेशन नेशनल अलायंस ऑफ सिकल सेल ऑर्गेनाइजेशन है. ये मिशन के पहले की कुछ तस्वीरें हैं जिसको राजस्थान को हम किस तरह से इस मिशन में शामिल कर पाए. उसके लिए हम नेशनल अलायंस फॉर सिकल सेल ऑर्गेनाइजेशन के साथ मिलके और हमने किस तरह से एडवोकेसी की, तब जाके राजस्थान को हम, क्योंकि जब एक टाइम था आज से 3-4 साल पहले मुझे ये बोला जाता था कि राजस्थान में सिकल नहीं है, और मेरी जब ऑफिसर से बात होती थी तो यही बोलते थे कि सिकल नहीं है. एंड देन मैंने धीरे धीरे से एक एक पेशेंट को इकट्ठा करके, और मेरा क्योंकि काफ़ी लेट डायग्नोस है, मेरा बायलेटरल एवियन है, मुझे गालब्लैडर स्टोन है, मैं 46 सेचुरेशन के साथ रिवाइव हुआ हूँ. तो मैंने बहुत से पेन्स देखे थे, तो मैंने अपने हिसाब से धीरे धीरे काम स्टार्ट किया, और एक दिन हॉस्पिटल के बेड में रह के ये सोचा कि शायद मुझे इस कम्युनिटी के लिए काम करना चाहिए. और मैंने हॉस्पिटल के बेड से जब ऑर्गेनाइजेशन को ढूंढा तो मुझे नेशनल अलायंस ऑफ सिकल सेल ऑर्गेनाइजेशन मिला. इनके साथ जब मैं मिला, ये मेरी पहली तस्वीर है नितिन गडकरी जी के साथ जो है वो, जहाँ से मेरी एडवोकेसी का पार्ट है वो स्टार्ट हुआ. एंड देन फिर धीरे धीरे हम मिनिस्ट्री ऑफ हेल्थ, मिनिस्ट्री ऑफ ट्राइब्स के पास जाके सेंसिटाइज करते रहे, और नेशनल अलायंस के साथ जाके मैंने बहुत कुछ सीखा. तब जाके हम राजस्थान को इसमें इंक्लूड करवाने में, ये हमारी कुछ वर्कशॉप हैं जो मिशन के आने से पहले की हैं. हम लोग इस तरह से छोटे छोटे लेवल पे, जब हमारा NGO नहीं इस्टेब्लिश हुआ था तो हम अपने लेवल पे इस तरह से वर्क करते थे. और मेरे अवेयरनेस की वीडियो कहीं CCMB CSIR के जो चिफ साइंटिस्ट हैं गिरिराज जार्डन के पास पहुँचे थे, जो गौतम डोंगरे सर के कारण गए थे, तो वो उदयपुर आए थे और हमने सिकल सेल पे इस तरह की वर्कशॉप की हैं। और ये सेंटर ऑफ एक्सीलेंस फॉर सिकल सेल डिजीज़ के साथ मिलके राजस्थान सिकल सेल सक्षम फाउंडेशन का 19 जून के जो प्रोग्राम हैं और अवेयरनेस के जितने भी प्रोग्राम हैं हमने किए हैं। साथ ही ये हमारे कुछ अवेयरनेस के वीडियो हैं। थैंक यू सो मच।
Hello. Now for the last talk, I would like to invite Dr. Arushi Goyal. So, madam, please come.
Good afternoon, everyone. So I am Arushi Goyal. I am a PhD student at CSIR IGIB, and I work under the guidance of Dr. Debojyoti. I am doing this presentation on his behalf. So I will be presenting on the topic of CRISPR-Cas prospects and challenges for gene therapy. So this is my lab at IGIB, and our lab primarily works on 4 branches. That is CRISPR-Cas based gene therapy, cerebral organoids for disease modeling, CRISPR-Cas based diagnostics, and RNA signatures in cell fate decisions. So we will be focusing here on gene therapy as that is of essence today. So first of all, why is gene therapy needed? So gene therapy can be used to correct defective genes, or it can be used to replace defective genes with a functional gene, and it can also be customized to various diseases. So it is very useful, and it is a one-time solution compared to other options that are available for the treatment of genetic disorders, which can only manage the symptoms and not cure the disease. So one of such diseases is sickle cell anemia, and we've already talked about the prevalence of it all over the world, in Africa and in India. And particularly in the States, everybody from these states have already discussed the scenario in their particular state. So as you will know now, that it is caused due to a single point mutation within the genome, where a single A getting converted into T results in the conversion of a normal hemoglobin into a sickle hemoglobin. So this sickle hemoglobin becomes more prone to polymerization and gives rise to the sickle shape of the RBCs, and which can cause vaso-occlusive crises, hemolysis, chronic organ damage, as have been discussed by others. So there are various treatment options which are available. Like there are few drugs such as, so crenalizumab, L-glutamine, hydroxyurea, all of which can manage the disease, as well as blood transfusions, which all of these need to be done periodically and repeatedly for the patient to have some relief from their symptoms. But there are 2 options by which we can have a complete removal of the disease, which is bone marrow transplant, which was talked about by Dr. Gaurav before me, and gene therapy. So here, our focus will be on gene therapy. So
there are two types of gene therapy, ex vivo gene therapy and in vivo gene therapy. So ex vivo gene therapy involves taking out the cells of the patients from their body, which in this case will be the hematopoietic stem cells. Then they are manipulated either through a lentiviral vectors to add the gene which is not present for the addition of a corrective gene, or it can be manipulative to correct that gene. And then these edited cells are again put back, infused into the patient. So this is the ex vivo part. For in vivo, directly these agents which are responsible for correcting the gene of interest are added directly to the patient. So my focus will be on ex vivo gene therapy. There are several ongoing trials already across the world which are using different types of approaches of lentiviral, CRISPR-based, etc. And they have gotten approval. So the first sickle patient which was treated with a CRISPR-based gene therapy is still thriving. Her name was Victoria Gray, and she has been treated for the past 4 or 5 years, and she's still doing very well. And this was published in 2001. Later, 2 years later, last December, we saw that FDA also gave approval to this Casgevy, which is the first CRISPR therapy for sickle cell disease. So what is sickle cell and how, what is CRISPR and how it can be used for genome editing? So it is a protein that linked with a piece of RNA can target any gene of interest. This RNA will be complementary in its sequence to the target gene. So when this RNA binds to the DNA, the protein finds its target and cuts the DNA. So there are two possible options, that either it can give us an insertion or deletion of some base pairs so that we get a error-prone repair mechanism, or it can be an HDR-based repair where if we provide it a template, then that template which contains the correct sequence gets incorporated so that we can directly correct that sequence. So in our lab, we are working with such a CRISPR-Cas mechanism, particularly FN-Cas9 protein, which is derived from a bacteria. So originally they used to give immunity to the bacteria, but they have been used for genome editing. And we have seen that our protein works better than the protein that is generally used by people all over the world, which is SP-Cas9, because this OT means off targets. So even if there are some changes within the genome, like if the target sequence and the off-target sequence are differing by a few bases, the SP-Cas9 cannot differentiate between them, and it still cuts that DNA. So that will give us a very error-prone mechanism, because it can go and cut other parts of DNA as well, which is obviously something we do not want. But with our protein, it can discriminate between the target and the off targets, and it does not leave the off targets. So it is a safer mechanism, and it will give us less off targets across the genome. So particularly for sickle cell anemia, as I was describing earlier, we can use this HDR mechanism where we can provide a template that contains the correct sequence. Or we can also use the NHEJ mechanism, which is deletions or additions within the genome to delete the expression of a particular gene. So as Dr. Gaurav was also talking about, that fetal hemoglobin switch, the switch of hemoglobin occurs at the time of birth. So before birth, we have fetal hemoglobin, which goes down after birth, and it is replaced by the adult hemoglobin. So this occurs due to repressors binding to the gamma globin gene. So for applying gene therapy, what we can do is this BCL11A, which is a repressor of fetal hemoglobin, can be targeted by CRISPR-Cas so that it induces some indels, some deletions in the genome of this BCL11A. So when this BCL11A will not be formed, then the fetal hemoglobin will be able to form. And this fetal hemoglobin then can compensate for the adult hemoglobin, which has converted into sickle for sickle patients. But for our technique, we will be focusing on rather the correction of directly the sickle mutation. So we will be providing a template DNA along with our protein, which will contain the correct sequence that needs to go and
get incorporated within the genome of the sickle patient. So once this incorporation occurs, we will get normal RBCs with normal hemoglobin. So this is not a compensatory mechanism, this is a correction mechanism. So this is a little bit of my data where we had tried this mechanism and gotten about 80% correction within the cells at the highest concentration. Second surprising thing that we saw was the absence of indels. So when we are doing HDR, when we want the correct sequence to get incorporated, the byproduct is some indels, which are because the repair mechanism within our cells is not perfect. So this is one of the cons of this technique. But with our protein, we have seen that we do not get absolutely any indels. So that makes it even more safer. Second is we wanted to test whether after the editing, the cells will be able to differentiate into the different populations, because we are editing stem cells. They are later supposed to make different kinds of blood cells, including RBCs. So we want to see whether they are able to develop properly or not. So here this assay was done to see, and we were able to generate proper RBCs, functional RBCs, even post-editing. So before going into any clinical trial, you need to validate your study through preclinical studies, which are done in animal or mouse models. Here we have chosen such a mouse model which supports the engraftment of human hematopoietic stem cells. These edited or control cells will be engrafted into the mice, and after 4 months it will be seen whether human cells have made up their population within the bone marrow of the mice, so that we know that whatever cell we put into a patient can go and home within the bone marrow, and so that the corrected cells can make up the bone marrow rather than the original faulty cells. So once we are done with this pre-engraftment study, we will move on forward to the scale up of this for a clinical trial for manufacturing of the cell therapy product. So here, firstly, the blood or the stem cells from the patient will be collected through apheresis, as was told by Dr. Gaurav. After this, they will be manipulated at the site of the gene therapy product manufacture. And after the manipulation, these cells will undergo many quality checks before they are put back into the patient, because we need to know that the cells are safe and they are sterile before they are infused into a patient. So after that, the patient will undergo myoablative conditioning, which means that all their original stem cells will be removed so that their bone marrow is now vacant for new corrected stem cells to enter and get engrafted there. So this will be my work at IGIB. So I hope this CRISPR-Cas based gene therapy can be a hope for all the tribals that are affected with sickle cell anemia in India. And thank you so much.
Please use mic. We have online audience also.
So about 700 to 900 million stem cells will be taken. Yes. So we can only try to correct all of the cells, but it is not guaranteed that entire 100% of the cells will be corrected. So as I showed in one of my data, that 80% of the cells got corrected. And we know from literature that even if 20 to 30% of the cells are corrected, that is enough for the person to function normally. So if like 80% are getting corrected, that is very well. Yeah, so this is one drawback of this therapy, that it is very, very costly. But since it is like a government-funded project, it is because the government is doing it. So for the initial few patients, it will be free of cost. It will entirely be done by the government. After that, we are only, because we are an academic institute, we can only do with the first phase of the gene therapy. Usually in US and in India, if you are taking up to the second or the third phase, it is usually done by companies which have a lot of funds for supporting patients. So we will only be focusing on the first phase of the trial. We are in the works. We are already ongoing. Our preclinical study is ongoing. And yeah, so this will be the first CRISPR-based trial in India. 3 in the first. So generally also in first phase of any in the first phase of any clinical trial, less than 10 patients are taken. So we are aiming to go for 3.
And when the first patient is to be taken?
Maybe in like 2 years.
Okay. Any other question?
So basically, after the removal of the cells from the patient, after the removal of the blood from the patient, we are going to select out stem cells because the blood will have other kinds of cells also. So we will be selecting out stem cells. We will culture them in our laboratory. We will correct them. After correction, we will again culture them for some time so that that correction gets incorporated correctly within the genome, within the DNA. And then we will perform different tests to know it is sterile, that no bacteria, no fungal, no other contamination is present. So selection is done based on antibodies. So these stem cells have a CD34 marker on their surface, and we use an antibody against that marker to select them out. Thank you so much.
Thank you so much, Dr. Arushi. Gene therapy made simple for all of us. Sir.
So, thank you very much, Dr. Arushi. And it was a, see this, why we brought up this topic is not because we want to teach you the science. This is because it is actually going to happen. It will depend on all of us how we push the state to bring it faster. They will need a lot of support. They will not be able to do anything in this country, let me tell you. There are a lot of obstacles everywhere. The files lie everywhere. So we have to create such an atmosphere that this is very important for the country. This is need of the day. And whatever they desire, there should be no stop. So they should get green line everywhere, a green light. And then only they'll be able to deliver us. We are counting on them. It's a very big problem. I was not in the room. I don't know whether she discussed the cost or not. Did she? So I will tell. So the 2 gene products have been approved in America. Casgevy and Lyfgenia. Do you know cost of these products? Anyone? No. So 2.5 crore per procedure. 2.5 crore. And if the country brings in, believe it, I am confident it will come close to free for all the patients. The people are already working with this philosophy that our cost has to be affordable for every patient because this is a cure for every patient. So we really wish you all the best. We are with you. Please, any support you need from all of us, the NGOs are here, the societies are here, the scientists, the doctors are here, and we are there to support you. And thank you very much for agreeing to come here and give us a presentation. Thank you very much. So there were 2 topics, Madhya Pradesh and Rajasthan, which we could not take up because both these doctors are, in charge for sickle disease from disease, both of them are busy in their local meetings. It's really tough because there is a sickle cell day and the government is really pushing the agenda very hard because government has and does realize that it's really very important topic for all of us. So that's why these 2 lectures we could not do. I had one small presentation on using medical officers for the for the care of sickle cell disease. So we are running district cancer care program in 6 states of India, along beyond 150 districts of India. where one nodal officer of the state is in charge of cancer in every government district hospitals, who offers free cancer care from diagnosis unto death, including free chemotherapy, everything done under the umbrella and by state governments. So state governments are doing a great job, and we want to really create a similar vertical for sickle patients under district sickle care program. That is our thought process. And I'm sure, because all these governments like Odisha, Chhattisgarh, Gujarat, Madhya Pradesh, they are running district cancer care program, so they understand these verticals, and we will be using, we want to translate this into sickle care program so that every second patient can be helped by a physician sitting in the district who has knowledge of sickle cell care. The model is very clear. No extra human resource creation, no extra employment of a doctor, using existing infrastructure, existing human resource, existing finance. That's the philosophy. And I'm sure we'll be able to turn around this philosophy into sickle care also. Thank you very much. That's all from my side. Any other comment or opinion, welcome, please. Huh? Can we get the presentations?
Yes, we can get the presentations. These are on our website, on YouTube also. So because of some internet issue, you could not see in the hall, but those all our 500 people online could see everything. That I already shared with your colleague. Okay, I have shared the YouTube link with also. And presentations on based on your request, you send email, we can send you. Yeah, I will request Dr. Arushi. Dr. Pendarkar will felicitate you. No. And I would like to thank everyone, all of you, all faculty who have traveled from all across, delegates, Sarvodaya Hospital team, our IT team, management team who have provided us the excellent food, and Dr. Pendharkar sir, who is inspiration for this program and make us work while running pillar to post with a great speed. And two things, two announcements before we close. Sir has given his go ahead for the next year on the World Sickle Cell Day program. Same in the hybrid format we will do in Delhi. It will come on the website sicklecellindia.com. That also on with the certificate of attendance you get on email. And we request all of you to give your inputs on what you feel that on this website sicklecellindia.com should come. We want to make it a comprehensive resource for all sickle people, be it the physicians, collaborators, NGOs, all stakeholders that way. So Dr. Shivaji has given his fantastic input, compendium, huge content. So I am already getting since morning a lot of things. So it is just a structure right now, so don't go by that. All of us together and people who are online, we have to develop it together over next couple of weeks. With that, I thank you very much, and online audience also. Once again, thank you. वो अनाउंसमेंट ऑनलाइन ऑडियंस के लिए थी, यहाँ के तो मैं रिक्वेस्ट एवरीवन टू जॉइन फॉर अ फोटोग्राफ हियर, एंड आई फॉर